Assalamu alaikum everybody. Welcome back to our activity for today about bacterial infections. أتمنى يا أخوان تكونوا استفدتوا اليومين الماضية، وإن شاء الله تكون مادة علمية مفيدة لكم. وعندكم الرابط يا أخوان، رابط الجهة المنظمة الدورات المستقبلية بمشيئة الله. Today we'll have some lectures that we are going to present, including salmonellosis, non-typhoidal, Evans syndrome, streptococcal, tetanus, toxic shock syndrome, tuberculosis, Yersinia, and hopefully we'll finish early as we did yesterday. We will have a break for عصر بري إن شاء الله بعد تقريبا 10 دقائق ونرجع الساعة 4 إن شاء الله. Again we'll have the same. رابط التحضير لسه يا اخوان لحد ما الجهة المنظمة ترسله، على العموم هتلاقوه في الشات بوكس بالنسبة ل رابط التحضير. So our first topic is about salmonellosis non-typhoidal, which is traditionally refers to disease caused by any serotype or organism in the genus Salmonella other than Salmonella typhi, the causative agents of typhoid fever. The most common manifestation of non-typhoidal salmonellosis is acute enterocolitis, but the organism can cause focal infection, bacteremia, meningitis, as well as enteric fever that may be clinically indistinguishable from that caused by Salmonella typhi. Non-typhoidal salmonellosis is a disease of considerable clinical and public health importance. An estimated 1.4 million cases of salmonellosis occur each year in the United States, of which a small fraction are cultured and reported. The direct patient care and lost productivity costs alone have been estimated to exceed 2 billion annually. But when one considers the added cost of plant closing, product recall, and loss of food production, the true economic impact of salmonellosis is likely to be substantially greater. Over 2,000 serotypes of Salmonella have been described. The nomenclature of Salmonella has undergone considerable evolution over recent years, which has led to some confusion. By DNA hybridization, two species, Salmonella enterica and Salmonella bungori, have been identified. Almost all clinical Salmonella isolated belong to Salmonella enterica, which is further subdivided into 6 species. Most Salmonella serotypes associated with the human disease belong to subspecies 1, but strains in subspecies 3, once referred to as Arizona grow, are occasionally isolated. Previously, the genus Salmonella was classified into 3 primary species, which were called Salmonella typhi, Salmonella cholera, and Salmonella enteritis. Arizona organism were in the separate genus. The Salmonella typhi, cholera, consisted of a single serotype each. The remaining 2,000 serotypes were in the species of Salmonella enteritis. The formal designation of serotype is Salmonella enterica, subspecies, enterica serotype. To avoid the awkwardness present in the previous nomenclature, we will designate each serotype directly without reference to the full species name. Salmonella enterica subspecies enterica serotype is written as Typhimurium and enterica subspecies. The two different organisms formerly known as Salmonella paratyphi and Salmonella java actually share the same serotype but are distinguished by the tartrate test. They are now referred to explicitly as tartrate positive or negative. Members of genus of Salmonella. As carrier, may shed Salmonella intermittently. Culturing specimen on 2 or more occasions may increase the likelihood of detection. In clinical laboratories, the enrichment growth is also recommended to increase the isolation of Salmonella from stool specimen. 3 selective enrichment media are in widespread use of isolate Salmonella. Many microbiologists prefer to use either selenate or tetrathionate without the brilliant green dye because neither inhibits Salmonella typhi in contrast to tetrathionate brilliant green growth. Numerous selective plating media varying from low to high selectivity have been used to isolate Salmonella from fecal specimen. The purpose of these selective media is to suppress the growth of other enterobacteria, Maconi, Eosin methylene blue, ABM, and deoxychelate agar are media of low selectivity. Salmonella shigella are widely used to screen Salmonella and Shigella because they support the growth of both organisms and are considered moderately selective media. When laboratory resources permit the use of additional plate, highly selective media such as a brilliant, a green, or bismuth sulfate agar may be superior to the less selective media. For specimen obtained from normally sterile source, such as blood or CSF, using selective media has no advantage. Following accepted microbiological methods, colonies that are suspicious for Salmonella should be further identified by chemical test. At least 2 representatives of each type of suspicious colony should be selected and transferred to either triple sugar iron, lysine iron agar indicate the decarboxylation or the amination of lysine and the production of hydrogen sulfide. The usual reaction of Salmonella will be an alkaline slant and acid bath. If a stool specimen must be transported, it as is often necessary in epidemiological investigations, a swab coated with feces should be placed in a transport medium and held refrigerated until it can be examined. Each serotype has a major determinant and 1 or more minor cosmetic antigens. Most serotypes that cause human disease fall into serogroup A and E. معلش يا اخوان الشات اتوقع لسه ما فتح بس شويه ان شاء الله بفتح شيء. Many clinical laboratories can readily identify serogroup using commercial polyvalent grouping anti-seria. DNA sequence-based approach to defining serotype of Salmonella are under active development and may soon begin replacing the traditional approach based on rabbit anti-sera. Since the 10 most common serotype account 66% of human isolates in the United States, laboratory techniques of further subtyping strains within a common serotype are often useful for epidemiological purposes. Antimicrobial resistant patterns are the simplest method of further characterizing an epidemic strain. Plasmid profile have proved useful in defining outbreak strains. Phagotyping scheme of Streptococcus salmonella, typherium, and other serotypes have been used extensively for epidemiological purposes in England and Canada. Pulse field gel electrophoresis of chromosomal digest shared through the PulseNet public health laboratory network has proven to be extraordinarily useful tool in outbreak investigations and for answering specific epidemiological questions. And now is the most common subtype used methods in United States. Yes, Dr. Karim. Yes, Ms. Karen, we are working in that to enable the chat box. I'm sorry for that. The antibody response to human salmonella infection has not been useful for the serodiagnosis. Salmonella enterocolitis does not always provoke measurable serological response. And the antibodies often cross-react with other bacteria. Testing for antibodies to the V antigen is useful for identifying typhoid carrier in epidemiological investigation. We will have يا اخوانا break صلاة العصر, then we'll be back. ايوه يا اخوان, حنشوف موضوع الشات مع الادمن بعد شوي, دقيقه بس. نشوفكم بعد الصلاه يا اخوان, بشيء الله. رابط التحضير بعد شويه يا اخوان في الشات بوكس، بعد شويه يا اخوان. The attendance link will be announced soon through chat box, so please be patient. Assalamu alaikum. Welcome back again. We'll resume our presentation for today. Salmonella are hardly and resourceful group of organisms. They successfully parasite a broad variety of hosts, including insects, reptiles, birds, and mammals. Although not true spores formers, they are resistant to drying and freezing and may survive for long periods in nutrient-poor environments. The organism can survive over 200 days in contaminated soil, 2 months in dust, and up to 5 months in roach and rodent feces. More than 3 years in dried whole egg. They multiply in food at temperature range from 7 up to 46 Celsius and can survive at pH as low as 4.5. Severe Salmonella serotype have been shown to survive quite well on the surface of fruits, vegetables, exfoliating possible conduit to the next colonized host. Many Salmonella have life cycle nature that guarantee long-term survival. Some have the ability to colonize a specific loci in gastrointestinal tract, tolerating the mild acidity of animal rumen or croup, or the bile in the gallbladder. Others have the ability to colonize the reproductive tracts of reptiles and birds, which means that the bacteria can infect the contents of eggs as they are formed. Resistance of Salmonella to antimicrobial agents has been a matter of increasing concern. Antimicrobial resistance is important for clinical and public health reasons. Although antimicrobial treatment is not necessarily an uncomplicated Salmonella enterocolitis and appears to prolong carriages, antimicrobial treatment is essential in the extraintestinal infection. The emergence of multiply-resistant strains can lead to treatment failure in this settings. Patients with antimicrobial-resistant Salmonella infection in food net sites were more likely to have bacteremia and were hospitalized at a greater frequency and duration compared to patients with susceptible infection. Antimicrobial resistance in Salmonella also has several important public health ramifications because of simultaneous exposure to antimicrobial is associated with increased risk of infection and resistant Salmonella. In one outbreak, 12 out of 18 infected with outbreak strains multiply resistant Salmonella. New reports had taken penicillin derivatives in the week before the onset of their illness. In most cases, illness began within 3 days after taking the antibiotic, suggesting that antibiotic provided a selective advantage for the resistant organism and converted asymptomatic colonization to overt infection. Without outbreak, 2 gallons of milk were contaminated, and the amount of implicated milk that person reported drinking was an index of the dose of Salmonella they had received. Some persons affected by the outbreak had taken an antimicrobial, which the outbreak strains Salmonella triforium was resistant just before becoming ill with salmonellosis. These persons reported drinking smaller volumes of applicated milk than ill persons not taking antimicrobial, suggesting that a smaller dose of Salmonella caused illness in the former group. At any given moment, some fraction of the population is taking antimicrobial for a variety of reasons. التحضير مرة واحدة يا اخوان في اليوم. التحضير مرة واحدة في اليوم. Because those persons appear to have heightened susceptibility to resistant strains of Salmonella and outbreak due to resistant strains may produce somewhat larger numbers of cases. From 16 to 64% of cases, an outbreak of resistant salmonella infection can be called excess cases, occurring as a result of this interaction between resistant and prior or concurrent use of antimicrobial. A more recent estimate of this included data from sporadic cases and suggested 13 up to 26% of salmonellosis cases could be attributed to the selective effective of taking antimicrobial of other reasons. Human infections are often related directly or indirectly to infection of animals. Transmission can occur by a variety of specific routes, including foodborne, waterborne. However, up to 95% of infection with salmonella in the United States are foodborne in origin. Produce items caused more than 10% of recent salmonellosis outbreak, consistent with a trend towards more outbreak of all etiologies due to fresh product. The typical foodborne outbreak is the result of at least 2 food handling errors. One of the permits of the contamination to occur or persist, and another that permits sufficient bacterial growth to reach the infectious dose. Epidemiological complexity of tracing the sources of specific contaminated food can be challenging. Infection with multi-drug resistant strains have been linked to beef in both outbreaks. If the serotype is rare, the molecular subtype of PFGE is available. It may be possible to trace it even further back. For instance, the international epidemic of Salmonella agona infection was traced to Bolivian fish meal used in poultry feed that introduced this formerly rare serotype several continents simultaneously, where it has since been resistant in poultry. In the United States, several serotypes have been associated with increasingly, though not exclusively, with particular fruit and vegetable food vehicles. Recurrent outbreaks due to one PFGE-defined strain associated with tomato have been traced in farms in one state by isolation of the outbreak strain. Foods may be contaminated in different ways. And kitchen food may be cross-contaminated from raw food or other sources. The incubation period after ingestion of Salmonella usually range from 12 to 48 hours, though longer incubation periods have been documented. The pathogenesis of Salmonella infection is incompletely understood. The multiplicity of serotype and animal host involved introduce much complexity. A serotype that is non-pathogenic in one animal species may produce severe illness in another. Laboratory models need to be interpreted with caution. The clinical expression of infection is affected by serotype and strain of bacteria. The status of underlying health and gut flora of the host, and the dose, vehicle, and route of transmission. Following ingestion, the organism traverses the gastric acid barrier and multiplies in small intestine. Bacteria penetrate the damaged intestinal mucosa, are ingested by macrophages, and may multiply in limited fashion in mesenteric lymphoid tissue. After more than a century of study, the virulence properties of this organism remain incompletely understood. Many potential factors and mechanisms have been described. The O-specific side chain portion of lipopolysaccharide is associated with invasiveness. The process includes several distinct steps, no single one of which explain the entire pathogenic spectrum. Salmonella can induce ordinarily non-phagocytic mucosal cells to engulf them and unusual ability to give them a rapid access to protected intracellular sites. Inflammation and tissue destruction, the fever, diarrhea, evidence of colitis that often accompany salmonellosis may be the result of local inflammation, effects of bacterial endotoxin, or of a specific cytotoxin that cause mucosal cell death. The outcome of infection is partially dependent on the number of ingested bacteria that reach the intestine. Small numbers of ingested salmonella may cause transient asymptomatic intestinal colonization. The minimum dose necessary to cause illness varies with serotype, vehicles, and variety of host factors. The host response to salmonella infection include asymptomatic colonization, gastroenteritis, focal soft tissue infection, meningitis, bacteremia, sepsis, and death. The pattern of host response may be dictated by the virulence of the specific strain, the size of inoculum, specific host factor, including age, gastric acidity. Disorders of gastrointestinal tract may predispose to enterocolitis, the defective cellular immunity, or reticuloendothelial cell function may predispose to bacteremia and invasive disease. Age is also an important determinant of host response. Bacteria and frank-urinary tract infection with salmonella is more frequent among older women and associated with specific serotypes such as Salmonella tennessee. The incidence of salmonellosis is higher among infants and the elderly, and the frequency of bacteremia is higher in both of these age groups. The mortality of salmonella infection is also considerably higher at the extreme of age. As demonstrated by outbreaks in nurseries and nursing homes, this convalescent carriage can be prolonged in young children. Paradoxical treatment with antimicrobials does not shorten the duration of carriage, but typically prolongs it, suggesting that the final resolution of the infection may depend on the competitive effect of the other gut bacteria. In person of the HLA-B27 genotype, acute salmonellosis can trigger the reactive arthropathy Reiter syndrome, leading to prolonged and recurrent episodes of joint pain, urethritis, and uveitis. The most important determinant of host response may be the organism itself. The clinical manifestation of the infection with non-typhoidal salmonella can be grouped into several clinical syndrome with some overlap. Acute enterocolitis, gastroenteritis is the most common syndrome of salmonella infection. This syndrome is characterized by a prolonged course with a prominent and sustained fever, anorexia, abdominal pain, splenomegaly, and headache. Localized intraintestinal infection may result in endoarthritis, particularly infection of atherosclerotic aortic aneurysm may occur in patients with a pre-existing atherosclerotic disease. Endocarditis is rare and usually occurs in abnormal valves. Infection and prosthetic heart valve also had been reported. The diagnosis of salmonella enterocolitis is made by stool culture. The diagnosis should be considered in any patient with moderate to severe gastroenteritis. The presence of headache or fever makes the possibility of this disease more likely. Compared to patients with these toxin-mediated disorders, persons with salmonellosis may have less important prominent vomiting and more likely to have prolonged diarrhea and fever. The control of salmonellosis depends on the understanding the routes and cycles of transmission well enough to interpret them. Control of foodborne salmonellosis can occur at many levels: at the farm, during the truck transport, a slaughter plant, or food production facility to the cook and consumer. In many countries, including United States, serotype that is highly pathogenic to poultry is Salmonella gallinara, has been virtually eradicated by vigorous flock and hatcher-based program of serological testing and destruction of infected birds. التحضير مرة واحدة في اليوم يا أخوان، التحضير مرة واحدة في اليوم. However, visual inspection cannot detect silent colonization, which is far more common. Slaughter and inspection safety practices based on hazard analysis. Unfortunately, the rendered product is often recontaminated with salmonella. Strategies include using uncontaminated sources of water or application of edible portion of the plant. I think that was the last slide. Any question, يا أخوان؟ عبد المجيد، صالحة، ريان، نورة، سامية، عوض، سلطان، بندر، في، زينب، سلمان، ميعاد، هدى، ريوف، قاسم، أحمد، عيسى، مريم، فاطمة، عبد السلام، كارن، آدم، غضهان، زينب، زهرة، محمد، سوزان، فاطمة، ماجد، فاطمة، عبد الرحمن، علاء، حنين، نوال. Thank you very much all of you. طيب يا إخوان، إحنا we move to the next presentation. We'll give you زينبي والسلايدات بنرسلها إن شاء الله بعد ما يخلص الكورس. كلموا الأدمن اطلبوا منهم السلايدات.
Be recorded too, so if anybody wants to listen to it afterwards, you guys can as well.
All right, so we'll go ahead and get started. Today's topic is management of Staph aureus bacteremia, and I'm Dr. Horn.
I'm Dr. Vivekananda.
And thank you all for being here. So we like doing this webinar and going over these topics, and we're happy to go over any topics that you have. This is kind of a series where we can cover topics and come back to them and really just go over antibiotics and infectious diseases and antimicrobial stewardship with really any of the topics that you'd like us to discuss.
We were going to talk about bacteremia in all general, but it's such a large topic, so we wanted to kind of divide and slowly conquer little by little. But if you guys have any questions on gram-negatives or fungemia, please feel free to ask us. So we'll get started. So one of our big philosophy is don't ignore Staph aureus in the blood. So even if it's 1 of 2 blood cultures or 2 of 2 blood cultures, if Staph aureus is in the blood, it's never considered a contaminant, and it's always considered real, and it should be evaluated and treated appropriately. And another interesting point is also when we get Staph aureus in the urine, it doesn't matter if it's MSSA or MRSA. Usually, the path for staph to get to the urine is usually transient bacteremia. So most likely the patient had a bacteremia and then got into the urine. Unless the patient recently had a urological procedure or had a Foley catheter placed, cystoscopy, recent straight cath, TURP, chronic indwelling suprapubic catheter, then it could be a colonization. But for the most part, if you find a healthy young female comes into the inpatient and she has staph in the urine, it should be worked up as does she have other sources of infection? Does she have bacteremia? So we should get blood cultures and we should consider treating. And you were saying earlier also it's important to kind of look at symptoms too, like in those cases.
Yes, and I think this is a really good point to make because oftentimes we'll get consults and you'll have bacteremia with staph aureus in the blood, and then we'll also be growing in the urine. And the clinicians that we talk to, they'll say, oh, it must have been gone from the urine and then gone to the blood. But actually, it probably went the other way around. That's what the evidence shows, is it probably went blood and then went into the urine. So if it's in the urine, we'd have to high suspicion it came from the blood.
Because Staph aureus is a skin flora, but it's not a urological flora. So you don't usually find it in your vaginal or in your groin area. So if you do find it in the urine, then high suspicion for was there a bacteremia and other source.
Yes. So if a patient comes in and they have it in the urine, they might say, oh, a week ago, I was having a fever. So then you'd say, oh, in my mind, I think that, oh, a week ago, they might have been bacteremia. And that's how it got into the urine. Is that what you think? Yeah. So if it's in the urine, consider checking the blood, make sure that they don't have any bacteria in the blood.
And then also, if you cannot find any other sources, no urological procedure, then I would consider treating that patient minimum 7 to 10 days to make sure we cover our bases. So control the source, removing the infected catheter and prosthetic device. So if you don't remove prosthetic device or catheters when we have staph aureus bacteremia, it's associated with prolonged bacteremia, treatment failure, and also can end up with death. Retention of prosthetic material is associated with increased likelihood of relapse. And Dr. Porter is going to touch base about this a little bit later. And the main reason is staph aureus causes this material to form called biofilm. So anytime you have a central line catheter, you have an ICD, pacemaker, any type of prosthetic device, and you have staph aureus bacteremia, it will tend to form this biofilm, and it's very hard to get rid of the bacteria there, and high risk for relapse and treatment failure. So controlling of the source is extremely important. I don't know, did you have that?
Oh, no, that's great.
And then also control the source. Evaluating for metastatic infection is very important. A lot of times when we take care of staph bacteremia, it's really important to do a really good physical exam of the patient, because they might come with just staph aureus bacteremia, but more we talk to the patient, then they'll say, oh yeah, I have this like lower back pain I have had for the last 2 weeks or a week. Or they might say, oh, the shoulder pain just showed up like 3 days ago. And the reason it's staph aureus bacteremia loves to seed in your spinal area, epidural space. It loves to seed in joint spaces, and also, of course, endocarditis and abscesses. So we tend to, when a patient has staph aureus bacteremia, really do a good physical exam, get a really good history, and make sure we evaluate all those high risk area to make sure we don't miss other sites of infection.
And this is why we wanted to focus so much on staph aureus bacteremia, is that it'll go places and stick places, it'll seed places. So even if you're treating it appropriately, they might all of a sudden have pain in their knee or in their ankle, in their back. They might have an abscess. So this is really why we wanted to focus on staph aureus bacteremia and really make sure that it's treated really aggressively. because even if you're treating appropriately, you can still have it going places, seeding, and causing problems in other locations. So it's really important to treat it aggressively and for a long duration.
And another trick always is when they complain a lot of times they have back pain, lower back pain. When you image the lower back area, if you just stop at the lumbar area, you'll miss the abscess that is below. So the Staph aureus loves to cause abscess in your lumbar spine area. But then what it does, it goes into the psoas muscle, which is your upper buttock area, and causes abscesses there. So it's really important to get nice spinal imaging with your psoas muscle and also image, so you can get a better picture if you're worried about lumbar area issues.
Yes, and that's a really good point. There are articles that say that the top mistakes when treating bacteremia, and one of them is when you image that you don't do enough imaging.
Yeah.
So that's a really good point. Is that even if it's say at a certain level of the back, you should go a little bit higher and a little bit lower. And I've seen that mistake. It's understandable to do that, but once you've seen that mistake before, you can understand that it's really important to image more of the back than you think is needed. Yeah.
And then what's also important, you guys look at this number. So if you have Staph aureus bacteremia, even if it's just 1 of 2 blood cultures, the chances of you having endocarditis is about 11 to 31%. So it's such a wide range. So that's why as ID physicians, we're always recommending if you have Staph aureus bacteremia to get echocardiogram to make sure we do not miss endocarditis.
Yes, and even going back to the first slide, that even if it's just 1 of 2 blood cultures are positive for MSSA or MRSA, you should still do an echo. You should still treat it very aggressively, and not as a contaminant. But sometimes providers will say, "Oh, it's just 1 of 2. I don't really need an echo." Right? So I would say yes. If I were the patient, I would want an echo. I'd want to make sure I don't have endocarditis. And then as far as what type of echo, whether it's a transesophageal or transthoracic, that's where the transthoracic can miss some that the transesophageal won't miss. So I every couple of years they'll come out with another study saying how often the transthoracic misses endocarditis, and I want to say it's around 8%. Sure. So
yeah, so they say that transthoracic echocardiogram only sensitive specific like 75%, but esophageal is like 90% sensitive and specific. So that's why us ID doctors always love esophageal, but not all patients can get it because, if they're unstable to have one or they have esophageal stricture. So in that case, at least getting a transthoracic minimum is required for these patients.
Yes, and different ID doctors, they came out with a survey and they asked, do you say they need a transesophageal or is it transthoracic okay? And different ID doctors will make different recommendations, but if I were the patient, I would want a transesophageal. So since it's pretty straightforward to order one and get one in our facility, some cardiologists will say, oh, you have to have a transthoracic first. And if it sees something, then get a transesophageal. Or if it doesn't see anything and you have high suspicion, then get a transesophageal. So whether it sees something or not, you're still going to get one. So
the thing about transthoracic is it can look at some of the heart valves, but not really the pulmonic valve or the tricuspid valve as much as the mitral and aortic. And the other thing about transthoracic echo is that it might, if you have abscess in your heart, it's not very good at picking it up. But transesophageal is really good at picking up those little details.
And then this slide is document clearance. So you want to show that the blood is clear of all bacteria. So repeat blood cultures recommended at 48 to 72 hours after initial positive cultures to document clearance of the bacteria. So you want to, once you have positive blood cultures, whether it's 1 of 2 or 2 of 2 or growing MSSA or MRSA, then repeating blood cultures after being on appropriate therapy for 48 to 72 hours. And then you want to make sure it's no longer in the blood. And then when you see that it's no longer in the blood and you document a clearance, that's when I start my clock as far as how long to treat. So I'll say it's from the first negative blood culture. So the first blood culture that has no growth, then you'd say, that's the first day I'm going to start. So I'll say, if I'm going to treat for 2 weeks, that would be day 1. And then positive repeat blood cultures are a predictor of metastatic infection or endocarditis. So if you keep having positive blood cultures, even though they're on appropriate therapy, it would give you higher suspicion that they have endocarditis, or they have a source that's not controlled. So they might have a large abscess somewhere, or they might have infected hardware or something where the bacteria is continuing to grow, continuing to get into the blood. And then repeat blood cultures positive do not repeat more frequently than 48 to 72 hours. So, and the reason that's there is because sometimes people will, right when it becomes positive, they will check it immediately, and then they'll check it again the next day. And then if they check it really quickly, it's more likely to grow. And also it becomes scary because they'll say, instead of having 2 of 2, then they'll say, oh, we've had repeat blood cultures for 3 days straight. Well, you need to give the antibiotics some time to work.
Yeah,
time to clear.
the time to work a little bit for the antibiotics is important. Yes.
Yeah, and then it gets really scary when they say, oh my God, we've had positive blood cultures for 4 days straight.
And also sucks because like
Yeah.
our patients get lobotomized and
Yeah.
lose so much blood. So 48 to 72 hours cultures.
Then treat the right drug at the right dose. So the most effective therapies. Okay. You would want to use cefazolin or oxacillin or nafcillin. And MRSA vancomycin is really the drug of choice. So we recommend giving vancomycin. And for bacteremia, a drop of 10 to 15 would be okay.
Yeah. You know, a lot of times what we see is if the patient is stable and they're just having bacteremia, a trough of like 10 to 15 is good, because you know, a lot of time our elderly patients, when we push the trough to be around 20, that's when they get into acute renal failure and all the other rest of the complications. So a lot of studies, there, you know, if you do a trough of like even 15, that should be plenty. There's no need to go to 20 unless they have meningitis or they're crashing in the ICU, you know, severe sepsis. In those cases, it's reasonable to do 18 to 20. But most patients, like you were saying, 10 to 15 is perfect for an MRSA infection.
Yeah, for straight bacteremia, if you push for a higher trough of 20, you're more likely to have kidney injury, and the outcome as far as the bacteremia is the same.
Yeah.
So the outcomes, it doesn't improve getting rid of it from the blood, but it hurts the kidneys and gives you more issues from.
Then you had dialysis, prolonged hospital stay, and all the other stuff.
Yeah, and then so MSSA, you want to use cefazolin or nafcillin or oxacillin, and then we're going to see in a second that cefazolin is actually superior to oxacillin and nafcillin. And here this is a comparative evaluation of the tolerability of cefazolin and nafcillin for the treatment of Staph aureus. So if cefazolin and nafcillin are essentially equal in killing the bacteria, then the question is, which one can the patient tolerate better? Can they tolerate cefazolin or nafcillin better? And it comes down to cefazolin is better tolerated by the patient, because once, let's say the patient has a rash on cefazolin or a rash on nafcillin, if you have a rash with nafcillin, they jump to vancomycin, and then you're going to be comparing vancomycin versus a beta-lactam. So if you're trying to compare cefazolin and nafcillin, if more people get a rash and don't tolerate nafcillin, and then they have to start on vancomycin, then you're comparing cefazolin with vancomycin. And really, patients have better outcomes when they have either cefazolin or nafcillin compared with vancomycin. And so this is a common question, and as far as residents and fellows that we work with, a common boards question is, what's the best drug for MSSA? And they'll put vancomycin and cefazolin there. And you have to know that cefazolin has a lower mortality, better outcomes, a lower length of stay. It's just all around better. So sometimes we'll talk to providers and the patient has MSSA, and we'll recommend changing vancomycin to cefazolin. And the provider will say, oh, well, it doesn't matter, they're already covered. Kind of, but not really. So because we have such better outcomes, you'd want to be on cefazolin or nafcillin.
So in my opinion, beta-lactams are always better to use them compared to vancomycin. So like in MSSA, when you can't use a beta-lactam, definitely go with the beta-lactam. And then when it comes to tolerability, if the patients don't have all these reactions, synapsal rash, sometimes renal injury, liver injury, cefazolin, they don't have all those reactions. So much better to just go with cefazolin, and they do really well. Another really nice thing about cefazolin in the dialysis patient, a lot of people ask us this question. It's really nice if a dialysis patient needs long-term cefazolin therapy. You could do cefazolin after dialysis Monday, Wednesday, Friday, or Tuesday, Thursday, Saturday. So you would give 2 grams, 2 grams, and 3 grams. So in those patients, you're not stuck putting another line in. Just like Vanco, you could do cefazolin after dialysis as well. So that's really convenient.
Yeah, so 2 grams Monday, 2 grams Wednesday, 3 grams Friday. Yeah, so that's a great way to do it. And then they wouldn't need an extra line.
Yeah.
And then alternative antibiotics for MRSA. So the preferred first line is vancomycin for MRSA. Now, if the MRSA MIC is 2 or greater, there's a high risk of failure and a higher mortality. So we would recommend not using vancomycin if the vancomycin MIC is 2 or greater. So we'd switch to an alternative antibiotic. You can switch to daptomycin or linezolid or ceftaroline. Ceftaroline is a 5th generation cephalosporin, and it's the only cephalosporin that works against MRSA, but it works very well. Not all facilities carry ceftaroline, but in cases where the MIC is 2 or greater, or they're having a lot of kidney injury from the vancomycin, then ceftaroline is a really good option.
And then if the patient's cultures are not responding, about 5 to 7 days, then you can consider alternative therapy too. The MIC part is really important to pay attention to, because a lot of times, like, that's what we always teach our residents and fellows. It'll show up on the lab report as it's susceptible, because lab guidelines, it's only resistance after 8. So it's 2 still would show as susceptible, but we know this is called MIC creep. We know if for MRSA greater than 2 MIC, bad outcomes for patients. So definitely that's important to kind of call and talk to the lab and get that information.
And sometimes one kind of common question we'll get is that the patient isn't clearing their blood for several weeks. So if they're not clearing their blood, then one option would be daptomycin plus ceftaroline. And this we'll get into in the next slide. This is called the seesaw effect. So this is when ceftaroline combined with daptomycin, and it's called the seesaw effect because the ceftaroline kind of changes the charge on the
Bacterial cell wall.
On the cell wall, and then helps get the daptomycin in. So it'll kind of seesaw the daptomycin in with the charge. So using ceftaroline plus daptomycin helps clear the blood a little bit faster than they otherwise would clear.
So in those refractory cases, we end up using 2 different agents. This slide kind of talks about echocardiogram again. We already kind of talked about it, but the main emphasis on this slide is transesophageal echocardiogram is preferred over transesophageal transthoracic echocardiogram because of the sensitivity and the specificity of identifying infection. PE is the test of choice for all patients with prosthetic valve, pacemaker, ICD, or persistent bacteremia. Follow blood cultures are positive. Like we talked about, in some patients, it's kind of hard to do, but this is the test of choice. Failure to treat for adequate duration results in increased rates of relapse and tends towards increased treatment failure. So with staph bacteremia, it's kind of important to know different scenarios. You're going to need different duration of therapy. So what we call uncomplicated staph bacteremia is when somebody has Staph aureus in the blood, but there's no other sites of infections. In that case, you could do 2 weeks of therapy, either MRSA vancomycin, MSSA cefazolin, like Dr. Horn was saying, from the day of negative culture, first negative culture for 2 weeks. But we call complicated Staph aureus bacteremia if they have staph bacteremia with cellulitis, wound infection, any other sources, then it automatically becomes complicated. Another important thing to know too, if somebody has persistent bacteremia, so when you repeat the blood culture and it's still positive, that automatically falls under the complicated category. So for all of those patients, you're going to need at least 4 weeks of therapy. And then if you have endocarditis or osteomyelitis, then the duration is even longer. It's 6 to 8 weeks of therapy. So that's why it's really important about what are the other sources, and then we could kind of go from there about the duration.
That was good.
Additional antimicrobial agents. We never give gentamicin for Staph aureus bacteremia. It really doesn't help clear the blood. It actually ends up causing more harm to the patient. It ends up causing more nephrotoxicity. We seldom ever give gentamicin as a synergic agent for Staph aureus bacteremia. Rifampin, there is a role. There have been some studies that they did when they looked at prosthetic joint infections in the knee with Staph aureus, and when they gave rifampin, what it did is it helped. The rifampin basically broke through the biofilm the Staph aureus creates, so the other antibiotic like vancomycin was able to enter and kill the bacteria. So in our current guidelines for prosthetic heart valve, pacemaker, prosthetic joints, you can't use rifampin as a synergy agent together. But you never want. A good point here is we never use rifampin alone because it causes resistance rapidly in a couple of days. So it always given with another Staph aureus agent.
Yeah, and that goes for like a prosthetic knee infection that you're going to give chronic suppression. You would never give rifampin alone as a chronic suppressive agent either. So, and that's a favorite test question. Sometimes they'll say, what do you want to give? And then they'll say, do you want to give Bactrim or rifampin? And then I'll give some other options. So Bactrim might be a good option for chronic suppression, but you'd never give rifampin alone, or else it'll develop resistance and it won't work. And that's the same here. You would never give rifampin alone. You'd always give it in combination. Okay, so this is, I thought this was worth putting here. These are steps to prevent central line infections. So there aren't very many ways that we know of to prevent central line infections, but these are the ways that are well proven and well shown to make a difference. So good hand washing, wear sterile gloves and hat when the essentially sterile procedure when placing central line. Clean with chlorhexidine. So chlorhexidine is the agent that's the best for preventing infections. And then remove catheters when they're no longer needed. So as soon as you don't need the central line anymore, you can take it out. But these are the best methods to prevent central line infections. And this is catheter and prosthetic device management. So recommend removing all prosthetic devices. The retention of indwelling foreign bodies is associated with 18-fold increase in the risk of relapse. So if a patient does have any kind of central line, we recommend removing it if they have bacteremia. Otherwise, it will seed the line, and then it will be harder to clear if you can clear it at all. So sometimes when we have a patient with bacteremia, with MSSA or MRSA, we'll have a new intern that will say, oh, they'll need a line. They're going to go home with a line, so they'll have it placed immediately before the patient has cleared their blood. And so we'll repeat blood cultures to document clearance of the blood. And if it continues to be positive, then that line will just need to come out because now it has stuck to the line, and it's just going to stick there with a biofilm and not be able to clear the blood anymore. So it's kind of a
and it's scary, 18-fold increase in risk of relapse. So
right.
That's why we always emphasize if you take out the line and stuff, it's really important.
So we want to document clearance of the blood before placing a PICC line or any kind of lines the patient's going to go home with. And here, this is catheter and prosthetic device management. So this is a picture of the biofilm. So the biofilm will attach both on the outside. Well, let's see, both on the outside and on the inside. So here's the outside of the line, and this is in the bloodstream. So you can see it's attaching on the outside, but on the inside as well. So patients that have port or PICC lines that are there for an extended period of time, the bacteria will grow on the outside or the inside. And so we recommend removing the line would be the first step. So whenever we get a patient that has an infected port or PICC, the first question is always, do they need the line? So if they no longer need the line, just remove the line. Patients that have ports, they may have been treated with chemotherapy years ago and the port was left in. And so the first question is, do you need the port? Sometimes if patients, even if they've just recently completed chemotherapy a month or two ago, if you ask the patient, they'll say, I'm not sure. And then what? They'll say that I'm going to be reevaluated with a PET scan or CT scan in another 6 months to see if I'm going to have more chemo. In those, I really strongly recommend removing the port at that time because you're not even sure if they're going to need it ever again. And if they get recurrent infections from it, it's more harm than good.
And it's so hard to get rid of Staph aureus from a prosthetic site. There are some times you could do antibiotic blocks, but that's usually for like Staph epi, coagulase negative Staph infection report. Or if you have like a gram-negative bacteria, if you want to do a gentamicin block. But with Staph aureus, it's really hard to get rid of because, as you guys could see, that big thick biofilm where the bacteria hides under, it's really hard to get rid of.
So if the patient grew Staph aureus or fungus or Pseudomonas, they really need to have it taken out. Here you can see, this is the biofilm here. It looks like essentially just mucus.
Yeah.
And so here's the biofilm. And then down here's another picture of the biofilm. You can see it attaches and then grows an extracellular matrix that encompasses it. So usually when people think of bacteria, they think they don't communicate and they're all just out for themselves. But the biofilm development is actually kind of interesting because they work together to make the biofilm. It actually has ways of it keeps the flow of the blood through it. So it keeps the blood so nutrients can come in. And it actually has specifically areas for waste to go out. And it all communicates with each other, which is very interesting. This is the same, biofilms are the same thing that you find in your sink. When your sink is full of gunk, those are biofilms. The same stuff that's on your teeth, those are biofilms. So it's actually kind of interesting, but you can see here it accumulates and it's hard to get rid of without treating for either an extended period of time, drugs that can break into it and get into it, like rifampin, or just removing it is the best thing. Here, this is catheter management. So short-term catheters, you can remove if possible. Long-term catheters, they should be removed unless there's a major contraindication. So sometimes if a patient needs to be on pressors in the ICU, we really recommend removing it if possible, because once it's removed, sometimes the patient gets off pressors very quickly and they do very well. But if they can't be removed, sometimes you just have to wait a little bit longer until it's the patient's a little bit more stable to remove it. Then here, this is kind of illustrating a PICC line, and it shows where you can get the infection from. So the skin organisms, the skin can cause infection here at the site. Contamination from the hub, so if it's not cleaned well enough when it's used, and contaminated into sick. So that's kind of that's more of a test question than one we see in real life.
And I think the reason we're talking about lines and stuff is like the most common cause of line infections that we see is either it's Staph aureus infection or it's coagulase negative Staph infection, which is like Staph epi. So, and this, whenever patients get Staph aureus infection from a line or port, it's kind of devastating, for the patient, all the procedures. So I think it's really important to like place the line properly, sterile techniques, and also maintaining the line is really important.
So here are the conclusions. Always repeat blood cultures for Staph aureus to document clearance of the blood. It's never considered contaminant, even if it's just one of two. So it really shouldn't be ignored. I would say not to consider fungus a contaminant either.
Yes.
So even 1 of 2 fungus, sometimes we'll see written in the chart that the patient's not symptomatic, so they're not going to treat it out with that.
That's a really good point. Because most of the time, the fungus that's in your blood is majority of the time it's Candida species. And anytime if anybody ever sees fungus in the blood, it's never a contaminant. And if you guys want to empirically put somebody on a therapy for fungal until you know better, you could always do micafungin because there's lots of different species of Candida and they're more resistant to fluconazole. So I think that's reasonable, but Candida is reasonable. But yes, Staph aureus and fungus is never a contaminant.
Yep. Yeah. And then MSSA treat with cefazolin over nafcillin. So really either one is better than vancomycin, but cefazolin is better tolerated than nafcillin. So it's the drug of choice. And MRSA, vancomycin is what is recommended. Echo is recommended for all Staph aureus bacteremia. MRSA, MSSA, you want to make sure that they don't have endocarditis. And investigate for a source of infection. So you always want to see if you can find a source to help control the source. And once it's considered source controlled, it's much easier to clear and to treat. Duration is determined by the source. So if they have endocarditis, the duration is set by that. So it's a longer duration if you have endocarditis than just straight bacteremia or osteomyelitis. Yep.
And then just remember to always kind of pay attention to the MRSA, MIC for vancomycin too.
Yep.
If it's more than 2, use a different agent as well. I think that's all we had, talking points, but we're
So again, we'll continue our presentation about the Staph aureus infection. I hope that you enjoyed the video. Despite major advances in medical arena, Staph remains an important agent of infectious disease in human host. Although initially disregarded as contaminant in cultures, Coagulase-negative staphylococci have recently gained great clinical significance and are recognized as potentially virulent pathogen associated with significant morbidity and mortality. The emergence of antibiotic resistance has also brought renewed attention to staphylococci. MRSA is now considered a major public health problem in both hospital and community setting. Most staphylococcal diseases localize in the skin and not fatal. Once infection becomes generalized, bacteremia cause mortality is great despite appropriate antibiotic therapy. House health and population-based survey have provided a wealth of data on community-acquired morbidity from staphylococci. Hospital surveillance begin from laboratory cultures reporting staphylococci. Hence, it may be underestimated in the incidence of disease when culture are not taken. Staphylococci can be recognized quickly and reliably on gram stain oxidate from most clinical specimens. Their lack of fastidious permits their growth on ordinary laboratory media. Selective media, such as that containing mannitol and 6.5 NaCl, have expedited recognition of staphylococcal grown from swabs of throat. Once grown, Staph aureus is identified by a positive coagulase test. there are over 30 species of coagulase negative staphylococci. Although many clinical laboratories do not routinely specific coagulase negative isolates, they can be distinguished by a variety of biochemical reactions. Staph epidermis account for the majority of clinical isolates, with Staph hemolyticus and Staph hominis next in frequency. Antibiotic sensitivity of staphylococci as measured by Kirby. This technique is widely used. The phage typing of staphylococci has permitted identification of specific strains. Molecular methods of typing, such as plasmid analysis or restriction, endonuclease analysis of whole cell DNA, molecular methods of typing, such as plasmid analysis or restriction, endonuclease analysis of whole cell DNA, are highly reliable in predicting staphylococci strain. Strain identification by antimicrobial susceptibility is unreliable. The serological diagnosis of Staph aureus bacteremia has been evaluated. However, these tests have not come into clinical use. Antibodies against an extracellular glycopeptide antigen and the coagulase negative staphylococci have also been used to distinguish between staphylococcal infection around prosthesis and the aseptic usage. Staphylococci are non-motile gram-positive cocci that may occur singly in pairs, short chains, or clusters. They are facultative anaerobes, but grow better under aerobic than under anaerobic conditions. Most strains Staph aureus produce hemolysis within 24 up to 36 hours on horse, sheep, or human blood jar plates. Staph aureus specifically bind a variety of human proteins and glycopeptides, including fibronectin and fibrinogen. Clinical isolates of coagulase negative staphylococcal infection appears to produce an extracellular polysaccharides. This serum layer also inhibits diffusion of antibiotics, impairing their ability to reach organisms. In addition, the slime material interfere with the lymphoproliferative response to mitogenes. Staphylococci have long been recognized as a hospital problem, and the policy of routine ongoing surveillance for hospital-acquired staphylococci disease is well justified. Coagulase negative staphylococci are now the leading cause of primary nosocomial bacteremia. The widespread use of invasive devices such as pacemakers, central venous catheters, and hemodialysis catheters has contributed significantly to the temporal increase in the healthcare associated staphylococcal infection. Serious staphylococcal disease may be acquired outside the hospital. In particular, community MRSA has been has become a public health concern. Staph aureus may be carried by normal people at various body sites without causing disease. The nose is the principal site of carriages. Cross-sectional studies reveal rates of 50% in persons outside hospital and higher rates in hospital nursing personnel. Staph aureus carriages in infants is determined by a combination of host environmental and bacterial factors. Staph aureus can be highly contagious through direct contacts with a large number of organisms present in regions. The conditions of host clearly influence the frequency and severity of disease produced by staphylococci. Within a household, any strains of Staph aureus can colonize family members and cause disease sporadically, or it may cause continuous and repeated episodes of infection. Infections with Staph aureus are worldwide distribution. A variety of underlying conditions predispose to Staph aureus infection. Extreme of age, recent influenza A vaccine, A infection, exfoliative skin disorders, autoimmune disorders, diabetes, chronic renal failure, liver disease, all of these increase the risk of infection. The use of antibiotic has clearly influenced the epidemiology of Staph aureus infection coagulase negative staphylococci, which are part of normal skin flora and are uncommon pathogens except in the presence of foreign body. Contact transmission has also been observed with MRSA among athletes. Transmission of Staph aureus outside the hospital occurs through person to person and spread within families or unnamed contact. Patients on broad-spectrum antibiotics have been shown to have increased shedding of resistant staphylococci. Foreign bodies enhance the likelihood that staphylococcal infection will develop by reducing the number of organisms needed to initiate infection. Staph aureus is a complex organism with a variety of bacterial products with potential for promoting disease. Potential virulence factors include surface proteins that promote adherence to damaged tissue. Genes that encode virulence factors can be located on mobile genetic elements. Humans enjoy a high degree of natural resistance to Staph aureus. The exact nature of this natural immunity is not clear and may be non-specific. Ig antibodies to Staph aureus demonstrated in patients with recurrent cold abscess may represent an abnormal immunologic response to Staph aureus. The capsular polysaccharide of Staph aureus inhibit opsonization and phagocytic killing by polymorphonuclear neutrophils, thereby facilitating the development of invasive staphylococcal infection. Staphylococci may infect and cause disease in virtually every organ system of the body. A boil or furuncle is an acute abscess of the skin subcutaneous tissue, such as lesions occur most commonly on face, neck, buttock, thigh, perineum, and axilla. Staph aureus accounts for 17 and coagulase negative staphylococci accounts for 12 in surgical wound infection. Mastitis due to staphylococci generally occurs in newborn and in women. Staphylococci pneumonia may present in one of three ways: lobar pneumonia, diffuse interstitial pneumonia, and localized area of pneumonia secondary to septic emboli with infarction. Diffuse interstitial pneumonia usually occurs after coincidence with influenza. The most prominent clinical feature is tachypnea and cyanosis with refractory hypoxia. Endocarditis complicate the course of Staph aureus bacteremia up to 30% of cases, often with devastating sequelae. Staph aureus was the most common cause of native valve endocarditis in large cohort of patients. Only 5% of all cases of infective endocarditis or native cardiac valves are caused by coagulase negative staphylococci. Any question يا اخوان؟ أي سؤال about Staph aureus? Dr. Abdul Salam is asking about the antibiotic lock model pointer catheter, and how do we elaborate more on that? As you know, sometimes in the central line, in many occasions we have to make it a longer period, despite sometimes there is an infection. And usually it takes more than 1 week or 10 days. So there is a request, or there is a need to replace central line, especially if there is no signs of infection at the site of insertion. There's no clinical evidence of infection. So do you leave it or not? So systemic antibiotic can be utilized to prevent bacteremia in case if you need the catheter to stay longer and you are still not sure that there is an infection or not with the line. This is the idea about the lock therapy that we're speaking about. I hope that I answered your question. أي سؤال يا أخوان من الأخوان؟ Yes, Abdul Salam, I answered your question. I hope it's clear for you now. Yes, Abdul Salam, if you are willing to keep the catheter, if you are not able to take the catheter out because you still need it and there is no signs of infection, you will give an antibiotic as a lock therapy. That's the idea. Like prophylaxis. Hala, Saman. Thank you, Abdul Salam. You're welcome. Lana, Afrah. Hala, Lana. Walid, Tariq. Al-Shayma. Anfal, thank you very much. Fatma, Zaid. طيب يا اخوان, we'll move to the next presentation. I'll provide you with a video presentation. It's about streptococcal infection.
In this video, we will talk about Streptococcus probably the highest yield streptococcal species of all of the different type of strep that we'll talk about. If you're going in order in the microbiology series, you'll recall that we've been following this flow diagram, talking about gram-positive bacteria, and then gram-positive bacteria get separated into one of 3 different categories depending on their shape. We've only talked about cocci so far, which are round or spherical shaped bacterial pathogens. And within that cocci category, we can separate staph from strep, depending on if it's catalase positive, which would be staph, or catalase negative, which would be strep. And in the most recent videos, we've talked about strep, so we're obviously going to continue that direction by talking about catalase negative strep. Now, within the broader category of catalase negative gram-positive cocci, or strep, we further subdivide depending on the pattern of hemolysis. In the previous 2 videos, you saw that we were talking about alpha hemolytic bacterial pathogens, namely Strep pneumoniae and viridans strep. But in this video, we'll now go to that center category and talk about beta hemolytic strep. Now, recall again from a few videos ago that beta hemolysis refers to the complete breakdown of hemoglobin on that plate, as you see in that image. Now, within the beta hemolytic category, we have to determine if we're talking about strep pyogenes or if we're talking about some other type of beta hemolytic strep. And the way that we do that is depending on the bacteria's response to bacitracin. So if it's bacitracin sensitive, it's Strep pyogenes, and if it's bacitracin resistant, it's Strep Agalactiae. In this video, we'll be talking about Strep pyogenes. So with that said, let's get started. As you just saw in our flow diagram, we're talking about a gram-positive, catalase-negative, beta-hemolytic strep, which is bacitracin sensitive. And that bacitracin piece is so important because it's going to differentiate this against Strep Agalactiae if the test writer doesn't give you any other information. This is Landsfeld Group A, so sometimes you'll see this written shorthand as Group A strep, or GAS if you're a third or fourth year medical student and you're on the wards, on the floors, and you read the shorthand in somebody's note. If you see capital GAS, that's Group A strep, they're referring to Strep pyogenes. This is also pyrrolidonyl arylamidase positive, or PYR positive. For both Group A and PYR, I don't need you to worry about what that means for the purposes of USMLE or COMLEX, but just know that if you see that, it refers to Strep pyogenes. This strep is featured in a chain-like growth pattern or a chain-like arrangement, which is not unique to Strep pyogenes, as you've seen already, but it is a buzzword that gets thrown around, and I think you should know it. Strep pyogenes is found in nasopharynx, and it's for that reason that it's highly associated with pharyngitis. If the test writer is going to give you an image of Strep pyogenes, this is what you're going to see. And you can appreciate in these images the chain-like arrangement of the cocci organism. So if you zoom in, you see it's cocci, it's a coccus, it's spherical, but it's organized into chains, and that's Strep pyogenes for you. So this is your overview, and just remember that bacitracin sensitivity is what differentiates Strep pyogenes against Strep Agalactiae, which will be the next video after this one. So obviously, I need to give you a mnemonic to remember this very easily, because this can be the difference between getting the question correct or getting the question incorrect if the test writer goes after those bacterial flow diagrams. So when you think of Strep pyogenes, you can see that it has the word genes in the name. And when I think of genes, I think of tracing the genes of pyogenes, and trace for bacitracin. So trace the genes of Strep pyogenes. And you're tracing the genes, so that tells you pyogenes or pyogenes, and you're tracing it for bacitracin. So Strep pyogenes is bacitracin sensitive. Super easy mnemonic. This can literally be the difference between getting the question correct versus incorrect on your board exam or in-class exam. Now let's talk about virulence factors. And virulence factors for Strep pyogenes are pretty important, although I would say that they're probably not as high yield as the associated clinical features that you see, because Strep pyogenes, as we'll talk about in a few slides, can cause this vast array of different clinical diseases and clinical syndromes. So we'll go through the virulence factors somewhat quickly here. The first two that I want to talk about, and I list them here together because they're very similar, is an M protein and a hyaluronic acid capsule. So the M protein inhibits C3b opsonization. And if you've watched the strep pneumoniae video, we've already talked about opsonization, which is when basically a bacterial pathogen gets tagged with C3b, and then those specialized macrophages in the spleen see the C3b and know that they need to get that bacterial pathogen out. The M protein in Strep pyogenes inhibits this process, which makes it harder for our immune system to carry out that function of opsonization, and therefore Strep pyogenes is much more virulent. The hyaluronic acid capsule is related because it inhibits phagocytosis, and phagocytosis is the end product or the end goal of opsonization. So these two processes are very much related. What's very important to note is that antibodies that the body forms against this M protein in Strep pyogenes is responsible for the pathophysiology of rheumatic fever. And the mnemonic you see on this slide, it all has to do with the letter M. So M protein causes rheumatic fever, so I'm highlighting that M, via this process called molecular mimicry. See M's everywhere. And what molecular mimicry refers to is that when you have mixing of epitopes between a bacterial pathogen and a native endogenous protein in the body, when the body's immune system wants to clear the pathogen, it sees an element of the pathogen which shares some type of structural similarity to an endogenous or normal protein found in the body. And therefore, the immune system incorrectly attacks part of the body, which it shouldn't be doing because it thinks it's attacking that same feature that it saw on the pathogen. And this is called molecular mimicry. Now, in the case of rheumatic fever, this is specifically arising because the immune system is undergoing molecular mimicry and it's attacking cardiac myosin protein. So it's the myosin protein in the heart that the body thinks is the strep pyogenes because the M protein looks like the cardiac myosin protein. And to really make this stupidly simple and explain it to you like you're in 5th grade, on the left, imagine you've got strep pyogenes, that's our bacteria, and on the right, you've got a heart. On the strep pyogenes, you see that streptococcal M protein shown in pink, and I've depicted it here as a diamond shape. And on the heart, you've got cardiac myosin proteins, which I've also depicted as a diamond shape, but let's just say they're a little bit smaller, and they're shown there in that different color in orange. Now, the immune system's perspective, you have these T cells come along, and the T cells get confused because of molecular mimicry. It sees diamonds in both areas, and it says, I need to clear diamonds. To be honest, the immune system can be really stupid at times, and this is the basis for autoimmune diseases. T cells come along and they go, diamond bad, must get diamond out. So it sees pink diamonds that are big, it sees orange diamonds that are small, and it kills both of them. So in the process of doing this, the T cells are not only clearing strep pyogenes by recognizing its M protein, but it's also attacking endogenous, native, normal cardiac myosin protein. Now, obviously, this is a gross oversimplification, but this is what molecular mimicry is, and this is the basis or the pathophysiology of rheumatic fever. So it's all because of that M protein, the molecular mimicry, rheumatic fever, cardiac myosin proteins. So just remember the letter M, and you should remember all that stuff I just mentioned. The last virulent factor that we should talk about is protein F. This is a fibronectin binding protein that promotes epithelial cell attachment. So in a nutshell, it makes it easier for strep pyogenes to get in. And the way that I remember this is protein F equals fibronectin, which fuses to epithelial cells. So I'm just changing letters here to make my brain remember the letter F. Protein F, fibronectin, fusion, aka attachment, and epithelial cells instead of epithelial cells. So that's it for the high yield virulence factors. Like I said before, where I think you should pay special attention are the clinical sequelae, all these things you see on this slide that can be due to strep pyogenes. Now, admittedly, this is a lot of stuff, so I'm going to do my best to simplify this for you. But the goal of this conversation is to train your brain to form those third order connections so that if you're taking an exam and you start to get a question that describes something like post-streptococcal glomerulonephritis, so they're talking about kidney stuff and edema and hypertension and oliguria, and then they just throw in there like 3 words in the vignette that the person or the patient had a sore throat a couple weeks ago. Now your brain should really connect those dots and go, oh, that's post-strep glomerulonephritis. We're talking about strep pyogenes. So you need to form these connections and understand that buzzwords associated with all of the clinical sequelae you see on this slide can all be related back, sharing a common connection, being that they're caused by strep pyogenes. So the way that you can organize this if you need a mnemonic, and I don't know how useful this will be for you, is that strep pyogenes, just rewrite it as strep pyogenes. And then you've got PAGINES for pharyngitis, acute rheumatic fever, glomerulonephritis, impetigo, necrotizing fash, erysipelas, and scarlet fever. So the Y doesn't stand for anything, it's just there. Let's run through these one at a time. This will be kind of rapid review style, and I'll just throw out the buzzwords that you should keep a lookout for. And again, start to train your brain to relate all of these buzzwords back to strep pyogenes. So pharyngitis, you're going to see tonsillar inflammation plus or minus exudate. This is a classic image. If you see this, it's strep pharyngitis. Usually the question is going to feature a toddler or a young child because this doesn't really infect adults as much as it does children. You're going to see some non-specific symptoms like a fever or lymphadenopathy, and you treat this with penicillin. And for the purposes of exams, especially for step 2, level 2 and beyond, know that the treatment with penicillin is there to prevent rheumatic fever because it's an untreated strep pyogenes infection that leads to rheumatic fever. And with that said, that's a good transition into rheumatic fever. So this will typically occur 2 to 4 weeks after a strep pyogenes infection. You'll see symptoms like Sydenham chorea, which is, irregular, non-repetitive movements of the head, limbs, and neck. And just like that molecular mimicry that we talked about with the myosin protein in the heart, there is a lot of thought that this is actually due to cross-reactivity against the basal ganglia. So the immune system incorrectly targeting the basal ganglia causes this aberrant movement. You can see migratory polyarthritis, pancarditis, pan meaning all layers. So you can see myocarditis, endocarditis, and or pericarditis. So all of the different itises of the heart. That's what pancarditis means. You can see subcutaneous nodules, as you see on this slide, and erythema marginatum, which you also see on this slide. So if you see a weird rash, train your brain to think about strep pyogenes. If you see abnormal movements, train your brain to think about strep pyogenes. If we're thinking here of rheumatic fever, and that's why we treat strep pyogenes pharyngitis to avoid getting to rheumatic fever. Now, a very, very high yield one is post-streptococcal glomerulonephritis. As the name implies, this is a glomerulonephritidity that occurs after a strep pyogenes infection. So this will follow either strep pharyngitis or strep impetigo. And the labs that they'll give you will show ASO titer elevations and low C3 levels. If you see those two things together, you really want to think about PSGN, post-streptococcal glomerulonephritis. On the images, which are very important to recognize, you'll see immune complex deposition in the glomerular basement membrane, and you'll see what's described as a, quote, lumpy, bumpy appearance on immunofluorescent microscopy. If you see symptoms like hematuria, hypertension, edema, oliguria, that should really trigger your brain here, because this is a nephritis, as glomerulonephritis implies. So if you see those symptoms, think post-strep, try to connect all these dots back to strep pyogenes. Now let's talk about impetigo. Very, very high yield picture in buzzword, honey-crusted lesions on an erythematous base. If you see that, stop what you're doing, don't pass go, select strep pyogenes, and treat it with mupirocin. Now specifically, I'm gonna throw this in for completeness sake, strep pyogenes causes the non-bullous type of impetigo, but if you have bullous impetigo, that's a different pathogen, so that's not strep pyogenes. Similar, let's talk about another rash, erysipelas. This is a well-demarcated inflamed patch or plaque. You can see in this image that it usually involves the cutaneous lymphatics and the uppermost layer of the dermis. And because of that reason, it's usually raised and very well demarcated. You can see that that red inflamed area on this person's face is very well demarcated. There's a crisp line between the erysipelas and the normal skin. It's raised up, and you can see involvement of the cutaneous lymphatics. That's erysipelas. Scarlet fever, this is the last one we're going to talk about. You're going to see pharyngitis, but associated symptoms of what's known as, quote, strawberry red tongue with circumoral pallor, which basically means whiteness around the mouth. So like the area around the mouth will be very white and pale, but then the other regions of the face will have the kind of normal flushing to it. And you'll see what's described as a sandpaper-like rash that usually spares the palms and soles. So these images are pretty high yield. Of note, this is a delayed type hypersensitivity reaction to an erythrogenic toxin A, which I didn't talk about on the virulence factor slide, but I'll include it here for completeness sake. Treatment, really briefly, penicillin is the answer. If they're allergic, use a macrolide. You can also use first or second generation cephalosporins. So here's your summary slide. Streptococci, it's a coccus, it occurs in chains, gram-positive, catalase negative, beta hemolytic, PYR positive, group A, and bacitracin sensitive, because you trace the genes. High yield virulence factors, M protein, which is responsible for molecular mimicry and a lot of the different pathophysiologies of the associated clinical syndromes and clinical diseases. Hyaluronic acid inhibits phagocytosis. Protein F binds fibronectin. Just remember your Fs and your Ms for protein F and your M protein. And treatment is penicillin. That's it. I know I flew through this one. A lot of good stuff here. A lot of important.
We'll move to our presentation about, I hope that you enjoy the video. Streptococci are large heterogeneous group of gram-positive spherically shaped bacteria, widely distributed in nature, and this includes some of the most important agents of human disease as well as members of normal human flora. Thank you, Abdul Salam. Some streptococci have been associated with mainly with disease and while others have been domesticated and used for culture of buttermilk, yogurt, and certain cheese Those known to cause a human disease comprise two broad categories. First, the biogenic streptococci, including familiar beta hemolyticus streptococci and pneumococcus. The organisms are not generally part of the normal flora, but cause acute, often severe infection in the normal host. Second are the more diverse enteric and oral streptococci, which are nearly always part of the normal flora and which are more frequently associated with opportunistic infection. شكرا هي. Measures in terms of mortality, morbidity, economic cost, 5 streptococcal species are of the major importance in human disease. Group A streptococci, Streptococcus pyogenes, produce a wide range of infections from pharyngitis and impetigo to bacterial sepsis, erysipelas, necrotizing fasciitis, and toxic shock syndrome. Their non-suppurative sequelae include acute rheumatic fever, acute glomerulonephritis. Group B, Streptococcus agalactiae, is currently the leading cause of sepsis in newborn infants and the frequent cause of postpartum infection in mothers. The pneumococcus and Streptococcus pneumoniae remains the most frequent cause of bacterial pneumonia in all age groups and is a common agent of otitis media, bacteremia, and meningitis. Pneumococcus streptococcus pneumonia remains the most frequent cause of bacterial pneumonia in the age group and is a common agent of otitis media, bacteremia, and meningitis. Among oral streptococci, Streptococcus mutans is an important principal agent of the dental carriers. The Enterococcus is part of the normal bowel flora and has increasingly isolated as an opportunistic invader, especially in nosocomial infections. Enterococcus is now a separate genus, but will be considered an honorary Streptococcus in this lecture and will be similarities in enteric Streptococci. Until the last decade, there have been few reliable sources of mortality data for any streptococcal disease. Cause of death coding classification have been revised about every decade, usually without sufficient details regarding particular etiologic agent. For example, patients may die heart failure without traumatic heart disease being specified. Bacterial sepsis may be due to group A or group B, streptococci as well as other organisms. Pneumococcal pneumonia deaths are frequently counted with those attributed to influenza virus. Most reliable data or morbidity from streptococcal disease focus on severe invasive infections from national and regional survey areas in the United States. The Centers of Disease, CDC, began passive nationwide surveillance for invasive group A streptococcal infection. Surveillance of group B streptococcal disease was subsequently added. In Europe, until recently, an informal questionnaire system has been used to track group B streptococcal disease rates, and pneumococcal disease has been assessed mainly by the review of published reports. Some national public health centers publish their own more detailed surveillance data of particular interest. There has been little monitoring of enterococcal infection and vancomycin-resistant enterococci except in the United States from reports of hospitals participating in the National Nosocomial Infection Surveillance System. There are few accurate data on morbidity from non-invasive streptococcal infection. Monitoring of recent outbreaks of rheumatic fever by CDC has been incomplete, and no mechanism of systemic nationwide reporting has been adopted. The global burden of severe disease, including acute rheumatic fever, rheumatic heart disease, acute glomerulonephritis, invasive disease, is at least 18 million cases with about 1.8 million new cases per year. The major streptococcal species associated with human disease, our grouping of species is more convenience than taxonomic purposes. Recent changes in taxonomy and nomenclature have been reviewed by Facklin and Kohler. The various streptococcal species have many biological similarities and differences. The genus name suggests a twisted chain, which describes the microscopic appearance of many species, especially when growing in broth culture. Most have polysaccharides group antigen associated with cell wall, and some have teichonic acids as a major or additional components. Pneumococci exhibit prototype bacterial polysaccharide capsule. The group A streptococci, in contrast, have M protein on their exterior surface, but this appears to play a similar role in helping the organism. The group B streptococci, like pneumococci, have polysaccharide capsule as their major surface antigen. Pneumococci, however, also have autolytic enzyme. The group A cell wall carbohydrate is polymer of ribose, and the human normally make antibodies to this antigen, but the role of antibodies has been controversial. This is now evidence that this antigen may play a role in C. coli streptococcal infection by inducing antibodies cross-reactive with cytokeratin. This could provide an explanation for the joint and skin manifestation of acute rheumatic fever of the guttate psoriasis. Vaccination mice with group A carbohydrate cross-linkage tetanus toxoid appears to induce antibodies that are protective against challenges with group A streptococci. Furthermore, the disappearance of acute rheumatic fever in the United States may be correlated with the replacement of rheumatogenic M type of non-rheumatogenic type in cases of pharyngitis. The streptococci are generally quite susceptible to penicillin, including most oral and Streptococcus angiogenesis group streptococci. Exception includes some pneumococcal and the group D streptococcal and enterococci. Although streptococci are generally resistant to aminoglycoside, gentamicin is sometimes used for its synergistic effect in combination with penicillin, particularly in patients with endocarditis due to very dense streptococci and enterococci. Chloramphenicol has occasionally been used in penicillin allergic patients, but other drugs, including erythromycin, clarithromycin, group A and B streptococci have never developed resistance to penicillin. probably because they are not naturally transformable as are pneumococci and enterococci. They are somewhat less sensitive to vancomycin and cephalosporin, moderately resistant to chloramphenicol. Group E strains have shown some tolerance to penicillin, but clinical significance of such observation is unknown. Tolerance to penicillin has also been suggested as one mechanism by which group A streptococci persist after treatment of pharyngitis. Of considerable concern is the recent emergence of strains with very high resistance to penicillin, multi-resistant serotype 19A strains, because they are not included in the 7-valent conjugate vaccine. Although group B streptococci remains sensitive to penicillin, some strains can be penicillin intolerant, which has been speculated as a cause of treatment failure in cases of invasive disease. Although group B streptococci remains sensitive to penicillin, some strains can be penicillin intolerant, which has been speculated as a cause of treatment failure in case of invasive disease. Another problem is the increasing resistance to erythromycin and clindamycin, which are used as an alternative to penicillin and antibiotic prophylaxis for allergic women. Resistant mechanism to macrolides and clindamycin have been identified as methylase gene ERM and ERB and TR, efflux gene MEF and MEF A and E. Group A streptococci pharyngitis is one of the most common acute bacterial infection. The frequency of this disease especially الساعات تضاف يا اخوان خلال الاسبوع القادم خلال كم يوم ان شاء الله. The severity of disease reflected by mortality rates declined concomitantly. This trend began long before the advent of antibiotics, suggesting the decrease in virulence or the increase of host resistance, or both. In the 1940s, penicillin became widely available, and death attributed to scarlet fever and puerperal sepsis, the two most common lethal forms of group A streptococci, became rarity. And group A streptococcal pharyngitis is quite significant. And since 1960s, only one population-based study of streptococcal sore throat and industrialized chemistry has been published. اليوم نخلص على الساعة 9 إن شاء الله. بين 8 إلا ربع إلى الساعة 9 مشيئة الله. The incidence of culture positive cases was 13 per 100 child years and was higher per 100 child years for serologically confirmed group A streptococcal infection. Confirmed cases of acute rheumatic fever dropped from 20 to 28 per year to a very few from 1975 and 1985. By 1980s, the rates had fallen to 0.2 up to 0.8 per 100,000 nationwide among whites, but with rates several times higher among other ethnic groups. الساعات خلال اليومين القادمة يا إخوان تنزل. بس طبعا متى تنزل بالتأكيد تتابعون مع الأدنى. In particular, interest was the observation that throughout this period, incidence rates were essentially unchanged in Hawaii and New Zealand. The development infection involves multitude of interrelated bacteria and host factors that vary enormously. Most of the acute pathologic effects of group A streptococci occur at this stage by causing pharyngitis or skin infection with invasion in the submucosal or subdermal layers. This is frequently accompanied by lymphadenitis, but rarely progress to bacteremia. The M proteins protect against phagocytosis and also downregulate complement activation on the bacterial surface. C5 peptidase is an enzyme that inactivates complement C5a and decreases chemotaxis and secondary inflammatory response. Group B streptococci also have mechanism to evade the inflammatory response of the host, including the antiphagocytic properties of the polysaccharide capsule of C5a, inactivating the enzyme similar to that of a group of streptococci and the C protein which bind the IgA non-immune fashion. Specific immunity to streptococcal infection is thought to depend on the development of antibodies to capsule and other surface determinants. Although most of our knowledge of the immune response related to the occurrence of antibodies in the serum, recent studies of mucosal immunity suggest that the first line of the host defense are the local level. They are known to be important in the recovery from established infection and probably function in the removal of the antigen from local and systemic site as safer group A streptococcal antibodies and are used clinically to determine if the patient has had a recent infection. التحضير مرة واحدة في اليوم يا اخوان. امس وقبل امس ما اعرف حقيقة، انا ما عندي جواب يعني ما لا you have to contact the admin. At present, group A vaccine remains experimental, but it appears that local immune mechanism may be more efficiently utilized and less likely to result in systemic side effects. Tonsillectomy or with adenectomy are frequent performed because of the recurrent throat infections, although children who have surgery experience fewer throat infection over the subsequent 2 years. Several national groups periodically issue detailed guidelines for the management of infective endocarditis. The major organisms include Viridans streptococci, bovis, granulolectia, and pneumonia, A, B, C, and G streptococci, and enterococci. Whereas it is used to commonplace to administer antibiotics prior to dental procedure for patients with a wide range of heart valve disorder, now only few limited diagnoses are considered for prophylaxis. Personal hygiene, adequate nutrition and housing, health, education, and access to medical care are all important factors in prevention of streptococcal infection. Administration of gamma globulin has been employed for prevention of various bacterial infections in immunodeficient patients, although passive immunotherapy was the only efficacious treatment for pneumococcal pneumonia in the years prior to advent antibiotics. Conventional approach to caries prevention have been successfully reviewed. The Canadian Task Force. France do not fluoridate, and Switzerland has replaced fluoridation with fluoride in domestic salt. Fluoride and mouthwash are probably marginal value in the communities for fluoridated water to prevent the dental caries. Any question, إخوان? أي سؤال? We'll have a video for almost half an hour about streptococci also. لا اللي حضرت مرة واحدة خلاص حتى لو طلعت ودخلت. الأول والثاني اليوم الأول والثاني ما أعرف والله يا أخوان. Okay, Juan, we'll start our video. It's again about streptococcus, but I guess it is important to have, if you from this course master the streptococcal and staphylococcal will be great, because most common organisms that you will face in your practice are streptococcus and staphylococcal. So we'll provide another video about streptococci.
So streptococcus. Is most important, but not the most common cause of bacterial pneumonia. There are other causes of pneumonia that happen more frequently, to atypical pneumonia or typical pneumonia that we'll talk about in other videos. But this one is kind of the most important one that you need to be aware of because of the severity. It's a highly inflammatory organism. Just like the viridian streptococci, this is a non-groupable organism. So remember in the other videos talking about group A strep or group B strep, that was based on the Landsfield groupings, which is determined based on the carbohydrates that stick out of the capsule that we make IgM antibodies to. Streptococcus pneumoniae, those C carbohydrates are hidden, so we can't make antibodies to the carbohydrates. It's an alpha hemolytic organism. So what does that mean? That means you're going to get that kind of slightly green tinge on the blood plate agar. So that's where it becomes kind of difficult to distinguish the viridian streptococci from Streptococcus pneumoniae, right? Because group A strep is beta hemolytic, group B strep is beta hemolytic. But the viridian strep are alpha hemolytic, and so is Streptococcus pneumoniae. And they don't have a group, so you need to have other ways for recognizing them. When it grows, you can see it grows in kind of these short chains, but it can also grow in diplococci. The other thing is we call it a cocci or a coccus, but really it's not truly coccoid. It's kind of lancet shaped. So you can see here, it's got kind of like this, almost like a bullet shape here. So that can be slightly helpful in determination, but as you can see, these organisms are pretty small, so might not be able to recognize its lancet shape. However, it is optogen sensitive. So remember that optogen is kind of a copper salt that you coat on a disc and plate on blood agar. And then when you plate it on blood agar with the optogen disc, you'll see kind of a zone of inhibition around disc whenever Streptococcus pneumoniae is growing. And that's one way that you can differentiate it from the viridian streptococci, because the viridian streptococci are optogen sensitive. Another way that you can differentiate it is bile solubility. I talked about that as well in the viridian streptococci video. So basically it will be lysed by bile, whereas the viridian streptococci will not. That is one way that you can differentiate the two organisms. It's not typically done. We don't typically have a whole bunch of bile just hanging around in the lab, but theoretically that is a way that you could differentiate Streptococcus pneumoniae from the viridian strep. So this is the same image that I showed in the viridian strep group, but just briefly, this is an optogen disc, and you can see that S. mitis is optogen resistant, so it's growing right up to the disc, while S. pneumoniae is optogen sensitive, so you're getting a nice zone of inhibition. You can also note the alpha hemolytic property of both the viridian streptococci and strep pneumo. I think First Aid has the mnemonic device that viridian streptococci grow in your mouth, so they're not afraid of your chin. I don't really love that as far as mnemonics go, because strep pneumo can actually be normal flora of the oropharynx for about 30 to 35% of people. Especially, it's much more common to see it as normal flora in children. So you just kind of have to be careful about that one. You don't want to go around thinking that you might not find strep pneumo in the mouth. There are 90 different types of strep pneumo, and they're identified based on basically immunologic differences in complex polysaccharides that make the capsule. This is the other test that I talked about in the viridian streptococci video. It's the bile solubility. You can see that the viridian streptococci are not being lysed, whereas the strep pneumo are being lysed. So you can see right there. Again, this one isn't really done all that often anymore. So I mentioned that there are 9 different types based on the immunologic differences in the complex polysaccharides that make up the capsule. This is kind of important because only the encapsulated strains are pathogenic. And of those strains, about 23 of them make up the majority of human disease. In fact, they account for about 88% of bacteremia and meningitis in adults, when we're talking about, obviously, bacterial meningitis. So it's a pretty important organism, and the antigenic diversity of the capsule actually plays a pretty big role. So strep pneumo can colonize the oropharynx, and in specific situations, it's able to spread to the lungs, the paranasal sinuses, or the middle ear. And it also can transfer to distal sites like the brain. So when we're thinking about the structure, you need to remember that the way that strep pneumo causes pathology is that it's really just highly inflammatory. It's a very inflammatory organism. So you wind up getting mass inflammation. And anytime you have mass inflammation, you're probably impinging on the function of an organ and its ability to do its job and keep us healthy. So we already talked about the capsule a little bit. C antigen, this is not the C carbohydrates that we talked about, because remember, this is not a Lancefield groupable organism. But the polysaccharide capsule is really great at precipitating C-reactive protein. Recall that C-reactive protein is relatively low in healthy individuals, but it spikes really quickly and really highly in the acute inflammatory state, which is kind of more evidence about how inflammatory this organism is. So it's going to, when you have a lot of C-reactive protein, you're going to recruit a lot of white blood cells and other factors to a specific place. The next thing is these teichoic acids. The organism has these, and it basically activates the alternative complement pathway. And remember, the alternative complement pathway can be pretty damaging. Anytime we're talking about complement, we're talking about, first off, creation of opsonins, right? That's the most important thing that complement does. But we're also talking about production of things like C5a and C3a, which are anaphylatoxins. So they're going to lead to production of a lot of different cytokines, as well as recruitment of things like neutrophils and other phagocytes. This organism actually has something pretty neat, a secretory IgA protease. So I already mentioned that this organism colonizes the oropharynx and can occasionally move into the sinus cavities. So that means it's hanging out in the mucosa. The immunoglobulin that is most responsible for protecting our mucosal sites is IgA. So what IgA normally does is it grabs onto a bacterium and then traps that bacterium in the mucus, and then the cilia kind of bat the bacteria out of the way. However, in this case, this organism just breaks up IgA with its protease, thus preventing the ability for the organism to be removed. There are only 4 bacteria with an IgA protease. This is one of them, Streptococcus pneumoniae, but Haemophilus influenza and the 2 Neisseриas, Neisseria meningitidis and Neisseria gonorrhea, also have IgA proteases. It's kind of a neat evasion strategy of these organisms. The last thing is pneumolysin O. This is actually a toxin, and it's produced by strep pneumo, and it basically causes damage to the epithelium. And it also has kind of an added benefit of inhibiting the oxidative burst that phagocytes do to basically kill organisms. So basically they require that in order for it to destroy the organisms it engulfs. So it inhibits the leukocytes' ability to do that. This also will activate the complement pathway, and anytime you're activating complement, once again, you're getting opsonins, C5a, C3a, and really systemic inflammation symptoms. So that's going to lead to secretion of your inflammatory triad, IL-1 beta, TNF alpha, IL-6, interferon gamma, anything that's going to lead to increased vasodilation, vascular permeability, fever, and all of those things that make us feel really, really awful. So one of the interesting things to note about strep pneumo is this Quellung reaction. And yes, it is a U, it shouldn't be an I, that isn't a spelling error, it is Quellung. So I already mentioned that strep pneumo has this interesting capsule around it. Well, we make antibodies to the capsule, and remember there's all these different serotypes. Well, when antibodies attach to the capsule, it actually allows for water to like swell in. So you get this like swelling, almost like a water balloon. It just like fills it up, and you can visualize that obviously as we're doing so here. This isn't normally done as part of diagnosis, but it is done during basically vaccine development so that we can track the different serotypes of strep pneumo that are regularly circulating within the community. There are vaccines for strep pneumo, but because there's so many different serotypes that account for human disease, we've had to be pretty creative in putting all of these different serotypes together. So there's a 23-valent pneumococcal polysaccharide vaccine that is used for children 2 years and older through adults, and that's because it contains T-independent antigens. It's really only polysaccharides. Remember, T cells only make copies of proteins. So really all we're creating here are IgM antibodies, right? Because we can't get to any of the other immunoglobulins without any T cells. Because there are no T cells involved, it's really not as effective in patients who have some sort of immunodeficiency or patients who have received some immunity. They're not as a strong response. So it's not as effective in patients with asplenia, a hematologic malignancy, HIV infection, elderly patients, or renal transplant patients. And when I say asplenia, I mean a lot of different things. So, there are some patients who had their spleen removed due to trauma or some maybe cancer or something. There are also patients who have like a functional asplenia, like patients who have had sickle cell. So those patients, this vaccine won't work very well on. So we have another vaccine, that's the 13-valent conjugated pneumococcal vaccine. And that can be used fairly effectively in infants through 2-year-olds and any patients who have some sort of cell-mediated immunity deficiency. This one requires 4 doses. Typically it is given to children at 2 months, 4 months, 6 months, and then 12 and 15 months as well. So I mentioned earlier that Streptococcus pneumonia is actually normal flora in about 30 to 35% of individuals. So that should tell you that there are places where strep pneumonia can be within your body where it's fine and you're not going to have any sort of negative repercussion of its presence. So what that also tells you is that there needs to be something that either moves it to a site where it's not supposed to be, or makes you more susceptible to its inflammatory effects. And that's true. There are basically some significant predisposing conditions that basically make it so strep pneumonia is a problem. So typically strep pneumonia hangs out in oropharynx. But there are conditions that basically lead to it settling within the lungs. And that's where we see this significant inflammatory response and where a lot of pathology comes from. The biggest one that we talk about and think about the most is antecedent influenza. Every year during flu season, hundreds, at least probably thousands of people wind up hospitalized from the flu. And many people die from the flu every year. People often don't really think the flu is that big a deal. Flu is an incredibly deadly virus because it's it's probably the virus that has killed more people in this world than any other virus, because it does so every year. But it isn't often the flu virus that's killing patients. It's that the flu virus makes them more susceptible to things like pneumonia from strep pneumo. So what happens is the flu virus lyses epithelial cells, it kills cilia, or damages them, and that makes it so that strep pneumo isn't normally cleared out. It isn't pushed upward, and now it has access because the epithelium is damaged. And that basically allows it to get into the lungs and cause pneumonia. A similar phenomenon occurs with COPD, where maybe the cilia aren't working as effectively. CHF, these patients often have trouble fully exhaling, respiratory problems. Anytime you're not having full use of your respiratory function, you are more at risk for streptococcal pneumonia infections. Alcoholism is an interesting one. The most common cause of pneumonia in alcoholics is Streptococcus pneumoniae. However, alcoholics in general are at higher risk for bacterial pneumonia. And there is another organism, Klebsiella pneumoniae, which is also famous for causing pneumonia in alcoholics. It's not the most common, but it is a very common cause of pneumonia in alcoholics nonetheless. Asplenia, I already kind of mentioned that one. People who lack a spleen, variety of reasons, right? Functional asplenia, like sickle cell, the microinfarcts in there, inhibiting function, people who have it removed. So all of this makes people more susceptible to strep pneumo infection. These people who are asplenic might wind up with sepsis from Streptococcus pneumoniae. Why? Well, the spleen is a filter. So normally it filters out phagocytes and antibodies that have attached to strep pneumo and made it so that they can leave the body effectively. But if the spleen is gone, you're getting less filtration, and you can live without a spleen just fine. You're just more susceptible to some bacterial infections like Streptococcus pneumoniae. And then the other one that is routinely brought up is individuals over the age of 65. That automatically puts you in a higher susceptibility range for Streptococcus pneumoniae. So disease occurs when organisms colonizing the nasopharynx and the oropharynx spread to the lungs, paranasal sinuses, ears, or meninges. Spread of Streptococcus pneumoniae into the blood or another body site can occur with all of these diseases, but it is recognized that some serotypes have a higher predilection for an invasive pneumococcal disease than others. Okay, so let's talk about the diseases that strep pneumoniae causes. First off, this one's kind of a gimme. It causes pneumonia. It's the most common cause of typical bacterial pneumonia in adults. So what do I mean by typical pneumonia? You could see some hemoptysis, so it's a productive cough with rusty sputum. Lobar pneumonia, consolidations, you can see this white patchiness down in the lower quadrants of or in the lower lobes of the chest x-ray. Patient obviously is going to have difficulty breathing with all of this going on. Sometimes patients will be in pain, myalgia, because you're also going to have spiking fevers. So that's kind of typical pneumonia. With typical pneumonia, you're not walking around. You're barely getting out of bed. You're having difficulty breathing. You're flat in your bed in the hospital or at the doctor waiting to go to a hospital or go to bed. This isn't really a disease you fight your way through. Patients will say things like, I was too sick to get out of bed. I was too sick to go to the doctor. So it can be, a very difficult disease to get through. This differs from atypical pneumonia. Atypical pneumonia is something you'll hear a lot about in the winter. We'll talk about it again when we talk about Mycoplasma pneumoniae. Patients with atypical pneumonia, they basically have this prolonged, dry, hacking, non-productive cough, like or some fevers that come and go, and they'll come to work or school, and they'll sit in the back of the room coughing all day long. And you're like, oh my gosh, as you're hearing them cough, if you're that sick, just go home. But they come in day after day because they're not so sick that they can't come in and infect everybody else. So they do it day after day, and eventually you're like, oh my God, just die already or get better. No, you guys don't say that. You're going to be doctors. So you probably don't say that. But either way, they continue to cough for weeks and weeks, but they're okay. They can still go about. Be safe in the comfort of your own home, even if you have atypical pneumonia right now. So for community acquired pneumonia, and I'm talking likely typical pneumonia, as a monotherapy, you can use levofloxacin. But if you're going to do multi-therapy, you can add in either like azithromycin or ceftriaxone and vanco, just depending on the severity of your patient. Okay, I mentioned earlier that strep pneumo could be an invasive disease. It is the most common cause of bacterial meningitis in adults. Typically, people older than the age of 40. If they are 20 years or younger, so if we're talking like adolescents to 20-year-olds, it might be, it's more likely to be Neisseria meningitidis. If they're infants, then there's a whole different set of organisms, including group B strep or E. coli. But for less than 20, it's N. meningitidis. But older than 40, S. pneumonia is the cause of most bacterial meningitis cases. You need to be able to differentiate between bacterial meningitis and viral meningitis. There's kind of two reasons for that. One, bacterial meningitis, you can do something about. You can treat bacterial meningitis. We have antibiotics. If you identify it early, the patient can be treated and likely will have no long-term sequelae as a result of it. Viral meningitis, for most of them, with the exception of herpes simplex virus, we can't do anything about it. Like we don't have treatments, it's just supportive. Bacterial meningitis often also tends to be much more severe. So if you miss bacterial meningitis and you don't start treating it early enough, the patient could die. The patient could have severe neurologic complications for the rest of their life. Viral meningitis, which can be very severe, is not typically as severe as bacterial meningitis. So you can't miss this. So how can you kind of tell them apart? Well, first off, you're going to do a lumbar puncture. You're going to collect the CSF. And when you look at the CSF, it's going to have a high amount of polymorphonuclear cells, so a high amount of neutrophils. And those will be big and evident. You'll be able to tell, the pathologist will be able to tell the difference in the nucleus. It's going to have a high protein concentration and a low glucose concentration. You'll see this, it's kind of key for diagnosing bacterial meningitis, because there are some bacterial organisms that cause meningitis where you might not see the organism on the CSF. So with strep pneumo, you are likely to see the gram-positive lancet-shaped diplococci on the CSF, but you can't always rely on that. If you see, something that has white cells, but the protein is slightly elevated and glucose looks normal, then it might be viral, it might be fungal. But if it's all three of these, you can't wait. You have to treat and you need to diagnose what it is quickly. There are empiric guidelines for treatment of bacterial meningitis. At where we practice, it's or where you guys will begin practicing. It's vancomycin and ceftriaxone right now. But your infectious disease clinics will put out kind of the susceptibilities for organisms throughout the year. All right, and the last thing that Streptococcus pneumoniae causes is parents calling in sick to work. Literally, it is the most common cause of otitis media or ear infections and sinusitis or sinus infections in children. Therefore, it is probably the most common cause of lost wages for parents. These are pretty self-limited, easily treated, and generally children will recover and all will be fine. So those are the diseases, pathogenesis, and structure of Streptococcus pneumoniae.
In this video, we'll talk about streptococcus.
Okay, any question from the audience? أي سؤال يا أخوان؟ قبل نطلع صلاة المغرب. شكرا لنا، شكرا محمد. معلش دكتور عبد السلام, it's out of my hands. آدم، بهية، تركي، سماح، داليا، نوال، هيام. Thank you very much, all of you. Nawal, Samir, thank you very much. Question is, what are the common found sites expect from sputum? Sorry, I didn't get your question. Doctor, please explain. I didn't get what you mean. وإذا تخليه في question and answer box, it will be better. لأنه الشات بوكس يتحرك بسرعة، ما لحق عليه. Yeah, sputum is known. I have no problem with that. Sir, I mean, where we commonly catch this Streptococcus pyogenes site. Yeah, if you make a swab, I would say it's like a throat swab of the patient cough and provide you a sputum. As we explained that the skin, sometimes there is a skin infection like cellulitis, or there is a bacteremia. So it depends, where is the infection is coming from? Is it localized? Is it systematic? So accordingly, you make you make the sample accordingly. It is not a must to be a sputum. But at the same time, if you are going to take a sample, make sure that you will do it before starting the antibiotics. Because if you start the antibiotics, then you ask for a sample, then it will be difficult to catch the bacteria, because the antibiotic will fight the culture itself, so it won't be able to grow. Streptococcus, as we said, that it can cause bacteremia, skin infection, myocarditis, in many locations, but basically it's the upper airway. I hope that I answered your question. آخر محاضرة الساعة إن شاء الله، نخلص الساعة 9 اليوم، 9 وقبلها. احنا حنرجع الحين وقت الصلاة، نرجع الساعة 7 و10 إن شاء الله. الله يحييكم جميعا. شكرا دكتور عبير. لا، ما يحتاج، اللي يحضر ما يحتاج، اللي يحضر مرة واحدة حتى لو طلع من الشبكة ما في مشكلة. طيب يا اخوان، we'll be back ان شاء الله. Well, thank you very much. Assalamu alaikum. Welcome back again to our activity. Our next topic is about tetanus. Tetanus is non-communicable infection disease of human and certain animal species acquired through environmental exposure. Clostridium tetani is an anaerobic spore-forming bacilli ubiquitous in the soil. The spores germinate to vegetative bacilli when introduced into the soft tissues of the host under conditions in which the partial pressure of molecular oxygen is low. The vegetative organism produce a potent neurotoxin that acts in the CNS, leading to muscular contractions characteristics of the illness. Tetanus can be prevented by active immunization with tetanus toxoid, which is chemically inactivated toxin, or by passive immunization with a specific immunoglobulins as part of post-exposure wound prophylaxis. Tetanus toxoid, which protects by inducing production of neutralizing antibodies, is both highly immunogenic and safe. Nearly 100% of recipients of primary immunization series are protected. Due to increasing use of tetanus toxoid containing vaccine over decades throughout the world, tetanus is becoming a rare disease. It is relatively more frequent in unimmunized older age group and in areas where immunization programs are less effective. Although a significant proportion of global tetanus case burden remains under immunized adults and children, a major burden of tetanus in the world is borne by neonates born to mothers who are not adequately immunized and are infected at or soon after birth. However, major progress has been made in the initiative to eliminate neonatal tetanus as a significant public health problem. In the United States and most developed countries, data on tetanus death come from national complications of this certificate, listing tetanus as the underlying or contributing cause of death. In such countries, this data probably may be reasonable, albeit incomplete, estimate of the total death from diagnosed tetanus. However, in developing countries where the great majorities of death occur in the neonatal period primarily outside the hospital, this certificate information may not be available or reliable. The recommended case definition revised 1996 for clinically compatible case of tetanus, acute onset of hypertonia and or painful muscular contractions, and generalized muscle spasm without other apparent medical cause. Confirmed case is a clinically compatible case as reported of healthcare professionals. Case notification is passive depending on physician initiatives, which make reporting efficiency highly variable. It is likely that only a proportion of these actually occurring are reported to national health authorities. In the United States, additional available information on cases reported on the Centers of Disease Control and Prevention, CDC, include patient immunization status, wound history, medical history, post-exposure prophylaxis, treatment, and outcome. In the United States, 614 tetanus deaths were reported, and compared to 528 deaths reported via passive surveillance system maintained by CDC. رابط التحضير في الشات بوكس يا اخوان. Also, during this period, reported death to case ratio have declined from approximately 50 to 10% overall. But ratio varied depending on age, immunization status. Case series from other developed countries have reported death to case ratio as low as 10 to 20%. It's likely that there is a bias toward reporting the most severe cases and passive surveillance systems. It is likely that substantial underreporting of cases continues. Similar underreporting has been estimated for both other developed countries. Tetanus is primarily clinical diagnosis, and laboratory usually plays a little role. Some cases are present without history or evidence of recent wound. The organism has been grown from wounds in the absence of clinical symptoms or signs. Although levels of circulating antitoxin at the time of onset of illness could suggest susceptibility to agent. Although such instances are probably rare, tetanus must still be considered a differential diagnosis, as long as the illness is clinically compatible. Clostridium tetani is a gram-positive spore-forming anaerobic bacilli, flagella attached bilaterally on the non-sporulating bacteria and motility. While there may be some tolerance for oxygen when oxidation production potential is low, for the most part, Clostridium tetani can be considered an obligate anaerobe. It grows optimally at 30 up to 37 Celsius, although depending on the strain, growth can occur from 14 to 43. The organism can be grown in a variety of anaerobic media, such as cooked meat, casein hydrolase, and thioglycolate. In contrast, low pH, extreme temperature, glucose, assorted saturated fatty acids, and potassium can inhibit sporulation. Spores are highly resistant to environmental agents. Spores can be destroyed by a variety of disinfectant and heat, although susceptibility varies by agent. Spores are resistant to boiling, but heating to 120 for 20 minutes will inactivate them. Clostridium tetani produce two exotoxins, tetanolysin and tetanospasmine. Tetanolysin is oxygen-sensitive hemolysin related to streptolysin, and the theta toxin of Clostridium perfringens that may play a limited role in the establishing infection. Tetanospasmine, the cause of the clinical signs and symptoms of tetanus, is highly potent in neurotoxin. The molecular approximately 150,000 Dalton is synthesized as a single polypeptide chain that is cleaved into light and heavy chain bound by disulfide bond and released into the medium. Addition of reducing substances at natural to alkaline pH enhance growth. Formation of spores can be promoted or inhibitory by a variety of factors, including media composition. In the 1960s, the incidence of tetanus neotarum in developing nations had been estimated to be under 50,000 cases annually. By 1973, recognized problem and surveillance, the estimate annual tetanus death worldwide shifted upward to 1 million, with 90% of that mortality ascribed to tetanus neonatarum. In 1989, the WHO adopted resolution to eliminate neonatal tetanus worldwide by the year 1995. And this was reaffirmed in 1990s. The objective of eliminating neonatal tetanus defined as less than 1 case per 1,000 births of each health district advances toward the goal were due to in large part of the use of the high-risk approach toward prevention of neonatal tetanus, in which supplemental immunization campaigns for all women of childbearing age are held in selected high-risk areas. which is identified by surveillance or other indicators. In the pre-toxoid era, tetanus was generally distinctly seasonal, with midsummer or rainy season peak in the temperate areas. Clostridium tetani spread from environment to humans, generally through contamination of wounds. The organism cannot spread from person to person. Tetanus is a non-contagious infectious disease. Clostridium tetani organisms are distributed across the globe. However, the greatest concentration are in warm climate with moist, fertile soil. The highest rates of tetanus disease have historically occurred in the developing world. Since the introduction and wide use of tetanus toxoid, geographic distribution reflects areas with under-immunized population. Among cases reported to the United States, the relatively larger proportion of tetanus-associated wounds occurred in outdoor setting. Because of wound and field conditions, war injuries frequently were associated with tetanus. It has been estimated that prior to availability of toxoid, 1 out of 100 serious wounds in a battle conditions was complicated by tetanus. Drug users may be at high risk of tetanus because of non-hygienic injection practices. However, heroin is frequently mixed with quinine, which lower the redox potential at the injection site. The incidence and complications of tetanus are inversely related to access. Routine prophylaxis immunization with appropriate wound care following wounds, and care following onset of symptoms. The differences in racial incidence in early series and the characteristics of mothers of patients with neonatal tetanus are strongly felt to reflect poor immunization. رابط التحضير في الشات بوكس يا اخوان. رابط التحضير في الشات بوكس. Outside the neonatal period, a variety of conditions have been associated with tetanus. Tetanus is caused by in vivo elaboration of tetanospasm. The circumstances of wound were known for 78% of these cases. Injuries in outdoor setting accounted for 30% of cases with acute wound. Injuries incurred indoor accounted for 20% of cases and 10% incurred under special circumstances. Neonatal tetanus occurs in newborn infants born to unimmunized women following infection of Clostridial tetani. لا حضر يا اخي، اذا انت شاك انه ما حضرت اليوم حضر مره ثانيه ما في مشكله. Training of birth attendants and clean delivery practices is a major step in not only preventing neonatal tetanus but also reducing other causes of neonatal mortality. The reported incubation period of tetanus ranges from 1 day to several months. However, the majority of cases occur within 3 days to 3 weeks after injury. Local tetanus, which is uncommon in humans, consists of painful spasm in confined area around the site of the original injury. The spasm may persist for weeks to months. The prognosis of tetanus that remain localized is excellent. Initial signs may be followed by involvement of multiple other muscle groups, hyperreflexia, and generalized hypertonicity. Tetanus occurring within the first month of life is a form of generalized tetanus. Symptoms of neonatal tetanus generally begin 3 up to 14 days after birth, but can occur from 1 up to 28 days of age. The diagnosis of the tetanus is made primarily on clinical grounds. Generalized stiffness, hyperreflexia, trismus, and characteristics generalized tetanic spasm strongly support the diagnosis. Absence of changes in the state of consciousness or sensory involvement add further support. The epidemiological history can also be helpful. Testing for antitoxin using ELISA can be performed on rapid basis to assist the assessment of immune status. Absence of circulating antitoxin at 0.1 international unit per ml or greater when the patient is first seen to support the diagnosis. In the event of isolation of organism from the wound, this is strongly supported. The differential diagnosis will depend on the clinical signs and symptoms. Trismus may be caused by dental caries, tonsillitis, peritonsillitis. Hyperreflexia may be seen in rabies. However, rabies is more often associated with changes in the state of consciousness. In addition to infection, varieties of poisoning and metabolic conditions can stimulate tetanus. Hypocalcemia tetani can cause generalized muscle spasms, but is not usually associated with trismus. I think that was the last slide. Any question, Ikhwan? أي سؤال? Thanks, Gia. شكرا نوال. ريان. طارق. عبد السلام. Thank you very much. دكتور عبد السلام. أمل. في. معالي. بندر. عوض. أماني. سماح. محمد. سعود. سارة. سيد. مناف. ريان. حسنة. ابتهاج. نورة. سعود. زياد. مريم. صالح. عبد الله. شعاع. تهاني. سلمان. جوهرة. زهرة. منال. وليد. لنا. علي. عبد الله. طيب, thank you very much all of you يا اخوان. I guess we have to move to the next presentation. نحاول نخلص اليوم ان شاء الله زي امس ان شاء الله او ابكر شويه. طيب. Our presentation is about staphylococcal toxic shock syndrome. Staphylococcal toxic shock syndrome, TSS, is acute multisystem febrile illness caused by Staphylococcus aureus. The accepted criteria for confirming case of TSS include fever, hypertension, diffuse erythematous macular rash, subsequent desquamation, evidence of multisystem involvement, and lack of evidence of another likely cause of illnesses. TSS was first described in 1978. The association between illness and focal infection with Staph aureus was by definition apparent in early reports of Staphylococcal scarlet fever. Surveillance of TSS began in the 1980s. A few states established active surveillance of TSS for brief periods of time, while others did little to stimulate diagnosis and reporting of cases. However, data from National Hospital Discharge Survey indicated that reporting of cases in the 1980s, while incomplete and variable by region, was not biased dramatically insofar as age, race, sex, menstrual status of the patient was concerned. Hospital record review studies in which both diagnosed and previously undiagnosed cases of TSS were ascertained in consistent fashion so as to minimize or eliminate both diagnostic and reporting bias. While recovery of Staph aureus from a vagina and other sites of infection is not one of the criteria of TSS, Staph aureus grow readily on most standard culture media and is readily identifiable by the clinical microbiological laboratory within 2 or 3 days. A variety of serological and immunological techniques have been used to test Staph aureus strains for production of TSS1. As noted above, these tests are not available outside few research laboratories. As noted above, this is convincing evidence that Staph aureus is the cause of TSS. In patients with menstrual TSS, Staph aureus can be recovered from vagina and cervix in 95 up to 100% of cases. In patients with non-menstrual TSS associated with focal wounds, Staph aureus is typically only organism found in lesion. Furthermore, experimental studies demonstrate that TSS-associated Staph aureus strains can cause a similar illness in rabbits. On the other hand, 70% of Staph aureus strains recovered from normal sterile sites in patients with non-menstrual TSS produce TSS-T1, suggestive that the other staphylococcal toxins, particularly staphylococcal enterotoxin B, are capable of inducing clinically indistinguishable syndrome. The picture that emerged with regard to these characteristics, while consistent, is by no means invariable or unique. Similarly, TSS-associated strains generally are resistant to penicillin, arsenate, cadmium, while being susceptible. Other characteristics that appear to distinguish these strains from the other Staph aureus strains include decreased production of hemolysin and lipase. TSS-associated strains also have been reported to be less likely to carry plasmid and more likely to carry lysogenic bacteriophage than controlled strains. The correspondence figure of TSS-T1 producing Staph aureus are 15% in the nasopharynx and 5% in the vagina. In these studies, both diagnosed and previously undiagnosed cases of TSS were ascertained in the unbiased way by reviewing thousands of medical records of hospitalized patients. The incident rate in men of some of the same age group, the later study, was constantly less than 0.5 in 100,000 patients. The overall estimate was 0.8 in 100,000 total population of hospitalized diagnosed TSS in the United States. Because TSS increased dramatically the incidence of the United States beginning in 1980s in comparison of previous years, it would be correct to say that epidemic TSS occurred at that time. TSS does not occur, however, an explosive epidemic in the same way that dengue and meningococcal disease do. Although strains of Staph aureus that produce TSS-T1 are, like other Staph aureus strains, transmitted readily by person-to-person spread. Substantial controversy have surrounded the interpretation of the observed changes over time in the diagnosis and reporting of TSS. Data from the passive national surveillance system suggested that the number of cases began to rise in 1978. Because of the documented impact of publicity on reporting TSS cases and the undoubted fluctuations over time and the likelihood that cases would be diagnosed or reported. While the 3 published hospital records review studies all suffer from having the relatively small number of cases of TSS to analyze statistically, the result of all 3 studies are inconsistent. The similarity of the pattern in Colorado is even more apparent if cases meeting only the authors' proposed clinical definitions of TSS and not the more rigorous collaborative case definitions are removed. TSS can occur in individuals of all ages and has been documented in all newborn babies and patients up to 80% of age. However, data from both passive and active surveillance systems and from the California records review studies indicate that younger women are at greater risk of developing TSS than older women. Cases in women between 35 and 44 of age are even less common. Furthermore, the highest age-specific incidence rate have been observed consistently in women between 19 and 24 years of age. Although it has been apparent since at least 1980s that TSS occurs in individuals of all racial groups. However, data from California Records Review study indicate that 15 to 34 years age group TSS does indeed disproportionately affect whites. Like all Staph aureus strains, those capable of causing TSS appears to be transmitted readily by person-to-person spread both within the hospital and in the community. There is convincing evidence that a nurse transmitted a TSS-associated strain, Staph aureus, to hospitalized burn patients, and suggestive evidence that some cases of post-operative TSS are due to nosocomial spread of the causative organism by hospital personnel. Outside the hospital settings, transmission between hospital and wife has been suggested by almost simultaneous appearance of TSS in both, as has transmission between mother and daughter pairs. It is assumed but not proven that transmission in all these instances was by direct person-to-person spread. TSS results from an infection within appropriate strains of Staph aureus in a susceptible host. Once nidus of infection is established, onset of symptoms typically occur 1 up to 3 days later. The best evidence concerning incubation period comes from patients with post-operative TSS due to surgical wound infection in these patients. The date when the infection became established is usually the day of surgery and thus can be determined unequivocally. The median incubation period in such patients is 2 days. When TSS is caused by Staph aureus infection of the vagina during menstruation, one onset of the symptoms is typically on the 3rd or 4th day of menstruation, although it can be earlier or later. Furthermore, bacterial products other than TSST1 that are made more commonly by Staph aureus strains recover from patients. For example, renal failures and TSS is probably secondary to hypertension-induced acute tubular necrosis. Biological properties of TSS1 have been studied in vitro and in vivo. Attempts have been made to develop an animal model of TSS. In vitro putrefied TSS1 had been shown to stimulate proliferation of T lymphocyte to inhibit immunoglobulin synthesis and to be a potent stimulator of interleukin-1 production by macrophages and monocytes. In an illness meeting all the criteria of established TSS cases definition is by very nature of the criteria severe, and the majority of such patients are hospitalized for treatment. The temperature elevation in patients with TSS, while sometimes modest, can be extreme, with temperature in the range of 104 and 106 being fairly common. The characteristics macular skin rash can be dramatic and obvious, with patient appearing bright red throughout. It can be subtle and difficult to appreciate, particularly in dark-skinned individuals, or it can be localized. Similarly, myalgia, thrombocytopenia, and involvements in the hepatic and renal systems can range from nil to severe. One study has suggested that the clinical spectrum of disease differs between menstrual and non-menstrual TSS cases. Appropriate antimicrobial therapy and initial episodes of menstrual TSS combined with discontinuing tampon use has been shown to reduce the risk of recurrent episodes during subsequent menstrual periods. Although some consideration was given to attempting to develop a toxoid vaccine from TSS1, soon after its discovery, no concrete steps in this direction have been taken. Given the high proportion of a population with naturally occurring anti-TSS1 antibodies and the relatively rarity of TSS, it would be a probability expensive and impractical to demonstrate that such a vaccine yielded a clinical protection. Most strategies for decreasing the incidence of TSS have focused on menstrual TSS and its relationship to tampon use. The proportion of menstruating women who use tampon fell from approximately 70% in the 1980s up to 60%, up to 50% in 1981, but it has rebounded for approximately 65% since that time. In response to epidemiological and in vitro laboratory evidence concerning the possible roles of tampon absorbency and chemical composition in determining risk of menstrual TSS, most tampon manufacturers have dramatically altered both the absorbency and chemical composition of their products. In addition, one brand of tampon found to be associated with high risk of menstrual TSS withdrawn in the market together in 1980s. All tampons now carry a label explaining the association between tampon use and menstrual TSS, describing the signs and symptoms of the illness. I think that was the last slide. Any question, Ikhwan? أي سؤال؟ Dr. Tariq Faraj is asking a very nice question. He's saying that is TSS only for female or male and female. Actually, it's I don't think the male are using tampon. So basically, it is designed for female because they are utilizing the tampon, and that's why we don't see it in males. And desquamation of the skin only happens in TSS, or there is other diseases have desquamation of the skin. There are other diseases, but we have to take the clinical diagnosis of the patient. As you said, that if there is associated with shock and fever and hypotension, how can I make diagnosis of TSS? Actually, shock and fever and hypotension, this is septic shock per se by definition. So you are going to look for the source of the septic shock. If there are skin manifestations, you can take like a biopsy or you can take a swab. Then you wait for cultural sensitivity, but at the same time, you start antibiotics anyway. So if you have septic shock, you will start antibiotic anyway. It doesn't matter if it's TSS or not. Sometimes you give antibiotics, broad spectrum antibiotics, and still you are not aware what is the causative agent. So I don't think it's a major issue that most of the infectious which have fever and hypotension. How can I make a diagnosis of TSS? Well, you can. I think you can if you make a proper clinical judgment and the clinical examination, examining all the system and organs, making sure that there are nothing else. And of course, despite this is not common disease in our country, but we have to put this in consideration. You may pass 1 year totally and you don't see this TSS toxic shock syndrome. So this is the good thing about it. Put in consideration that in our area, the antibiotic access is easy, but in other developing countries, the access to the antibiotic is almost limited. So you may see that in the developing countries. I hope that I answered your question, Mr. Tariq. التحضير يا اخوان في الشات بوكس. Relationship between well, we said that the toxic shock syndrome, it has some species of the staph staphylococci that produce toxins and lead to such infection. So I advise you, I'll provide you with the PDF of the lecture so you can review it again, Dr. Khawla. Sorry, if Khawa Ahmed. So I'm not really sure about the name. Okay, so we'll move to the next presentation. The next presentation is about tuberculosis. And I think everybody is aware about tuberculosis. It is a contagious disease spread through the air in tiny droplets nuclei, propelled into the air by cough, sneeze, or speech of a person sick with pulmonary tuberculosis. Mycobacterium tuberculosis bacilli can stay suspended for a prolonged period of time, ready to be inhaled by others sharing the same airspace. Mycobacterium tuberculosis usually result in latent infection controlled by cellular immunity and may later progress to active disease. Though primarily a pulmonary disease, tuberculosis can affect many organs and continues to be a major cause of illness, disability, and premature death throughout the world. Tuberculosis has been curable for more than 50 years. Standard drug regimen of a specific antibiotic for a minimum of 6 months is required. In 1997, WHO carried out the first worldwide survey of global burden of tuberculosis and estimated that on average, one person is infected with tuberculosis every second of every day. Even so, most of these people will probably never know they are infected and will never develop active TB disease. The impact is so massive that despite improvement in case finding and treatment completion, tuberculosis increased at annual rates of 1% worldwide until it peaked, began to stabilize to 2005. The widespread development and subsequent transmission, multi-drug resistant tuberculosis in regions suffering from collapsing public health infrastructure. Worldwide tuberculosis death and death rates are tabulated in World Health Statistics annually. Although majority mortality rates has been useful historically as indicators of tuberculosis trends and of regions with tuberculosis. Tuberculosis cases and case rates are accumulated and summarized in publication from WHO and CDC. A distinction should be made between reporting TB cases and suspect to health department and counting of TB cases. There are currently 82 recognized species of myobacteria, most of them ubiquitous in the environment and not pathogenic to humans. Myobacterium tuberculosis complex include Myobacterium bovis africanum, Myobacterium, and other than Libra Myobacterium tuberculosis complex are referred to non-tuberculous myobacterium. Tuberculosis is small cylinder, 1 up to 4 nanometer long and 0.6 nanometer in diameter, and slightly curved, rod-shaped bacillus that reproduce slowly, approximately once every 24 hours. Using sophisticated mechanism to utilize the host iron and oxygen to survive, Myobacterium tuberculosis is able to persist for years, frequently for the lifetime of the host. Tuberculous bacilli are particularly resistant to drying. High lipid content makes bacilli resistant to dyes, routinely used to stain organisms in laboratories. They are susceptible to moist heat, being killed in approximately 30 minutes by exposure to temperature 60 Celsius and less than a minute when greater than 70 degrees Celsius. Laboratory studies have demonstrated that ultraviolet light can disrupt the DNA of Mycobacterium tuberculosis, killing the bacteria. The incidence and prevalence of tuberculosis infection and disease vary throughout the nation of worldwide. As a consequence, unknown but significant proportion of tuberculin reactors continue to harbor living organisms and at risk of reactivation for the rest of their lives. And thinking epidemiologically about the development of tuberculosis in populations, it is important to look at each of the two major stages of its pathogenesis. Tuberculosis can and sometimes does occur in sharply localized outbreaks. In nearly all such instances, this involves the exposure of previously unaffected people to the infectious individual in crowded quarters. A study published in 2000 that reviewed the outcome of the contact investigations reported to the CDC from July 96 up to June 1997. 36% of all the contacts were TB skin test positive, and only 21% of children younger than 6 years of age were positive. There is good evidence that the dosage of infection is related to the risk of developing the tuberculosis. Both among nurses and a Profit survey in England and white Indians children in Western Canada, the infectiousness of tuberculosis patients appears to be rapidly reduced by adequate chemotherapy. The most convincing study to prove this point came from controlled trials in Madras, India. Because of the importance of the cellular immune system in controlling infections with Myobacterium tuberculosis, it's not surprising that people infected with HIV are at increased risk of both reactivation and primary TB. 2003 reported the result of international survey designed to measure the burden of tuberculosis in the context of HIV. Several studies have shown that people who are most reactive to tuberculin are also most likely to develop tuberculosis disease later on. On entry to the Navy, recruit routinely received a skin test with PBD-S and also with PBD prepared from non-tuberculosis myobacteria, either the so-called Betay or Guaic strains, currently named as Myobacterium ovium intracellular. Among recruits with the intermediate reactions to PBD-S and larger reactions to either PBD-B and PBD-G, and subsequent case rates was essentially the same as recruits with less than 6 millimeters of induration, suggesting that their reaction to PBD-S were due to cross-reaction from non-tuberculous myobacteria. Tubercular bacilli are generally transmitted to human in only two ways: the inhalation of tubercle bacilli in droplet nuclei and by ingestion of contaminated milk. Tuberculous testing of dairy cattle and pasteurization of milk had nearly eliminated bovine tuberculosis. When the individual with tubercle bacilli in the sputum, cough, sneeze, talks, and the larger particles fall out of air promptly and appear to be of little danger. When they are inhaled, they can be trapped in the upper air passages or in ciliated portion and tracheobronchial tree, but may pass directly to the alveoli. Aerosol respiratory treatment, emblaming, and autopsies have all proved their potential to introduce communicable droplet nuclei to the air. After tubercle bacilli are inhaled or ingested, they are engulfed by macrophages and carried to regional lymph nodes, occasionally passing to the bloodstream and then to many organs of the body. The myobacteria waxy cell will resist attack or digestion. Initially, it causes little or no reaction in the host tissue. Phagocytes that contain tubercle bacilli may then be encased by effector cells, and infected cells are then killed, resulting in foci with central caseous necrosis and peripheral zones of epithelial cells, lymphocyte, and fibroblast. The range of possible outcome is extremely varied in many organs and tissues. Blood-borne tubercle bacilli show no evidence of becoming established. Host resistance may be inadequate from the start, and the infection may progress to active disease. The specific factor is responsible for the inability to control the infecting organisms at either time or not yet known. The type of clinical disease that develop after infection depend on the considerable extent of the ability of the host resistant to halt multiplication of the bacilli in the chicks. While pulmonary disease is the most common presentation, extrapulmonary disease is not unusual. Those who progress rapidly to disease after initial infection have a greater risk of extrapulmonary manifestation, particularly pleural disease. There is evidence that extrapulmonary tuberculosis is more likely to occur in people with immunosuppressed, either innate or acquired. Children appear more likely to develop extrapulmonary tuberculosis, apparently because of the immature immunity. A proportion of tuberculosis cases with extrapulmonary disease increased from 16 to 20% per thousand, while the overall rate of new TB cases continues to decline in the United States since national reporting began in 1953. Immunization against tuberculosis is currently limited to the use of BCG. An attenuated organism named for the two French investigators. As unexpected result, they note that the organisms cultured in this way lost virulence for laboratory animals. After 13 years of subculturing and testing, they become convinced that they had developed a strain of organisms that would remain avirulent and could be used to immunize a human against tuberculosis. A meta-analysis of 15 control trials intracutaneous BCG vaccination concluded that the average efficacy was 50%. It was concluded that much of the variability was due to latitude surrogate for the prevalence of non-tuberculosis myobacterial infection with the least protection at lower latitude. It has recently been shown that currently available BCG strains differ in their genetic makeup. Unfortunately, there is currently no way other than long-term studies to assess the efficacy of strains. Because of uncertainties regarding the efficacy of most BCG vaccine strains, the decision on the use of vaccination must depend on the part of availability of other means of tuberculosis control. I think that was the last slide. Any question يا اخوان؟ اي سؤال؟ Before we go to the عشاء break. احنا باقينا محاضرة واحدة يا اخوان بعد صلاة العشاء ونخلص على 9 ان شاء الله. داليا، وليد، ايام thank you very much. رغد، عبد الرحمن thank you very much all of you. سلفى، امل، كارمن، اماني، فارس، نوره، بندر، محمد، جهني، صالح، انفال thank you very much. عبد الكريم، عبد السلام. والله بس هو يعني المشكله انه احنا لازم نلتزم بالبرنامج، ولا انا ودي اخلص معكم حقيقه، لكن بنحاول قدر الامكان نلتزم بالبرنامج يعني. للاسف ما نقدر نعدل كثير يعني. الله يحفظك طارق، شكرا جزيلا. شكرا يا فاطمه، شكرا عبد السلام، الله يعطيك العافيه. اتوقع فيه كورس ثاني عن الفيرال انفكشنز يا اخوان، اسالوا المنظمين، ماني متاكد ولا تسجلت ولا لا. is interested. عبير، احمد thank you very much all of you. باقي محاضره واحده يا اخوان، الان بريك صلاه العشاء ونرجع الساعه 8:40 وبعدين نعطي اخر محاضره ونخلص اليوم ان شاء الله. نخلص قبل 9 بمشيئة الله يا اخوان. اثير ثانك يو فيري ماتش. عبد العزيز، اي عادي يا اخوان، اللي طلع من الزوم ورجع بس يرجع على طول يعني. خلوا الزوم مشبوك يا اخوان، اهم شيء لا تفصل الزوم. حطه على السايلنت وصلي وارتاح واشرب لك قهوه وارجع. شكرا تهاني، شكرا انفال. اي عاد اي انفال يا دكتور انفال، لا تطلعين من الزوم، خلي الزوم، لا تطلعي من الزوم عشان لان الوقت يحسب عليكم. خلي الزوم، حطيه سايلنت وارجعي يعني تيك يور بريك. لا حد يطلع من الزوم يا اخوان. لا ما يحتاج تسجيل مره ثانيه، تسجيل مره واحده في اليوم فقط. الساعات اتوقع خلال الايام الجايه عبد العزيز، بس الافضل تسال الادمن، المنظمين هم اللي يعرفوا متى يدخلوا الساعات، بس خلال الايام القادمه يعني. شكرا يا عبد العزيز، الله يعطيك العافيه. طيب يا اخوان، we'll be back على الساعه 9 الا ثلث ان شاء الله، وان شاء الله نرجع بعد الصلاه ان شاء الله. وطبعا اهم شيء يا اخوان التحضير يا اخوان، رجاء لا احد ينسى التحضير. التحضير يا اخوان رجاء، لانه بعد الصلاه على طول ان شاء الله بنخلص محاضراتنا ان شاء الله، ونخلص بدري اليوم ان شاء الله، ما نطول ان شاء الله. المحاضره الاخيره ما نطول فيها. التحضير يا اخوان، لا تنسون التحضير رجاء. الشات بوكس اليوم اخر يوم، نعم بعد الصلاه اخر محاضره مشيئه الله. يعني قبل 9 واحنا مخلصين بمشيئة الله. شكرا محمد، شكرا رفيف. اي نفسه اليوم اذا حضرت مره واحده خلاص كافي، هو التحضير مره واحده في اليوم. اذا حضرت يا عبير قبل كذا كافي. شكرا. طيب نراكم على خير يا اخوان بعد نص ساعه تقريبا، الساعه 9 الا ثلث تقريبا، و واللي باك ان شاء الله. والله اللي نسى يحضر امس يكلم الادمن بس ياكد معاهم. لا يا هاني ان شاء الله ما في اشكال، بس يعني حاول تنسق مع الادمن مع المنظمين، بلغهم من عندك عذر، تعرف يعني عشان ما يحسبوا عليك فنسق مع المنظمين. والله ما اعرف يا عبير، هذه تسالي فيها الادمن صراحه. الادمن اللي سجلتوا معاهم يا اخوان، اللي دفعتوا لهم الرسوم وهم اللي دخلوكم في الدوره هذه، فرتبوا معاهم ووصلوكم بالادمن. اهلا امل، شكرا جزيلا. طيب يا ريان نراكم على خير ان شاء الله بعد نص ساعه تقريبا. ما اعرف والله يا انفال، يعني هذه حاجات تكنيكال، ما والله ما اعرف يعني إذا رحت في تطبيق اخر يطلع ولا لا ما ادري، ما اعرف. إيه اذا فصل تواصل معهم يا هاني. نعم. لا ما يحتاج تحضر من جديد، التحضير مره واحده فقط في اليوم عن طريق الرابط. التحضير مره واحده في اليوم، اذا سجلت خلاص، الزوم اذا فصل ولا شيء ترجع فيه مره ثانيه، عشان كذا احنا نسجل في الرابط. طيب يا اخوان نراكم على خير بعد نص ساعه ان شاء الله. Assalamu alaikum. Welcome back for our last presentation about Yersinia intercalatica infection. Hopefully we'll finish soon. The three bacteria of genus Yersinia are recognized in human pathogen. Yersinia pestis is the cause of plague, devastating epidemic disease transmitted from rodents reservoirs, and evolved from Yersinia pseudotuberculosis, a cause of episodic disease in animals. Yersinia intercalatica is recognized as a cause of human illness around the world. Also cause intestinal infections and is transmitted from animal reservoirs through the contaminated food. Only few phenotypic variants have been conclusively associated with human or animal disease. Other strains have been associated with important animal disease, but the strains that cause human illness are carried asymptomatically in their animal reservoir. Yersinia intercalatica is psychotrophic, which means it can multiply in the temperature approaching zero. The growth on cooked meat and in milk at low temperature is well documented. This temperature dependent of biological characteristics may be important to survival of the organism outside the host and for the pathogenesis in the host. Unlike most other aerobic bacteria, most strains of Yersinia intercalatica do not produce iron-binding compounds. The virulence of human pathogen strains of Yersinia have been extensively studied and depend on a variety of molecules and mechanisms. Several of these are mediated by the virulence plasmid known as PWV. Adherence and invasion of the mucosal cells occurs via invasion of other surface proteins that are chromosomally encoded. Infections were recognized in the 1970s when global awareness increased and widespread dissemination may have occurred with a real subsequent increase in incidence. Broader approach that estimate the number of all illnesses rather than just those being cultured arrive at substantially higher estimates. Outbreaks of yersiinosis traced to specific sources are unusual but eliminated. The remaining outbreak affecting a mean of 2.5% each were reported from Austria, while a few well-characterized outbreaks of enteritis due to Yersinia have been reported in Europe. Several outbreaks involved in commercial milk, which likely become contaminated after pasteurization. The first of these occurred in 1967, and illness occurred in 222 skilled children and employees. Among hospital population, typically occurs as sporadic illness and very rarely as outbreak. Some underlying health conditions, such as iron overload and HIV infection, can predispose person to yersiinosis. Another nosocomial outbreak occurred in Canada in the 1980s, in which 9 patients in total were identified, some only by enrichment culture. Human infection is usually acquired by the oral route. The dose required to cause disease in human is unknown. Though one volunteer became ill after consuming 3.5 multiply 10 power 9 organisms. In some persons at high risk, particularly those with iron overload syndrome, infection can disseminate from gastrointestinal tract through the portal vein. Although there is a considerable evidence that both natural and experimental infection can confer some degree of immunity, the degree to which it is serogroup specific. Yersinia intercalatica infection in human can range from asymptomatic carriages to acute gastroenteritis to pseudoappendicitis. Acute Yersinia gastroenteritis is marked by diarrhea, abdominal pain, fever, dysphoria, nausea, and vomiting. The syndrome of mesenteric adenitis, terminal ileitis, or both are more likely to occur in children and adults. In these patients, diarrhea is less prominent. The most common extraintestinal form of Yersinia infection is reactive arthritis, and non-suppurative arthritis has been reported most frequently in persons of Northern European descent. Diagnosis depends on isolation of the organism from clinical specimens such as stool or blood. Tonsillitis and localized right lower quadrant abdominal pain is diagnostic clue. Race and ethnicity are important because they may reflect differences and specific exposure. The rates of infection have been shown to be lower in Muslim population which avoid pork. It has been isolated from human in many countries in the world, but is found most frequently in cooler climates. Distribution may reflect differences in frequencies in infection. Serogroup 09 BioVar2 is the second most common in Europe, but its distribution is uneven. The relative proportion of serotype was first reported in Europe in the mid-1980s. A clustering of cases during the cold fall and winter months has been reported in some European countries such as Belgium. Vaccines against Yersinia enterocolitic infection have not been developed. The high frequency of immune-mediated complications of yersiniosis in human has tempered enthusiasm for such research. Attenuated strains have been used as means of delivering other antigens in experimental vaccine model. Although it caused a number of clinical syndromes that vary with age, sex, and health of host, children appears to be preferentially affected. The illness most commonly associated with Yersinia in children less than 5 years old is febrile diarrheal illness, indistinguishable from that cause other enteric pathogens. التحضير يا اخوان بالله التحضير لو سمحتم. We are almost done. التحضير يا اخوان اللي ما حضر يحضر بس. In general, rates do not differ by sex. In most studies, males have slightly outnumbered females in all age groups of patients with Yersinia diarrhea. Unresolved problems, despite better understanding of the biological properties of the organism and its unique geographical and environmental distribution, many questions about ecology, epidemiology, and pathogenicity of Yersinia remained unanswered. Although considerable progress has been made in our understanding of the routes of transmission and reservoirs of Yersinia, which is well-designed epidemiological investigation, particularly case control studies are needed to identify risk factors and determine their relative importance in the endemic areas. The evolutionary link between Yersinia enterocolitica pestis and pseudotuberculosis suggests that this genus may differ more general answers to the questions about how pathogens evolve. I think that was the last slide. Any question يا اخوان؟ أي سؤال يا اخوان؟ احنا خلصنا هذه آخر محاضرة يا اخوان هذا الكورس. تحضير يا اخوان بالله اللي ما حضر. ثانك يو زياد مناف ربيع. الساعات اسالوا خلال الايام القادمه يا اخوان بس اسالوا الادمن. نوره عوض هاني حسنه سميحه انفال. جوهرة أتوقع خلال الأيام القادمة تواصلوا مع الأدمن لو سمحت. أحمد، عائشة، أتمنى تكونوا استفدتوا يا أخوان في الكورس. السلايدات حتكون PDF إن شاء الله عند الأدمن إذا احتجتوها، ونتمنى تكونوا استفدتوا وتكون يعني كورس نافع لكم إن شاء الله. لا، التحضير مرة واحدة، إذا قطع النت ورجعت التحضير مرة واحدة فقط، ما في إشكال. لو حضرت مرة ثانية احتياط ما في مشكلة. عوض ثانك يو فيري ماتش. معاذ، فاطمة ثانك يو. ريهام، أشواق. لا خلاص ما في محاضرات، خلصنا يا أنفال، هذه آخر محاضرة نقدر نطلع. نعم اللي بيطلع يطلع. ثانك يو إيري، ثانك يو فيري ماتش. أسماء، فيصل، عبد الله، جميلة، نزار، دونافيلا، محمد، عائشة، جوهرة، فهد. ثانك يو اول اوف يو يا اخوان. نراكم على خير ان شاء الله. ايام، ثانك يو فيري ماتش. الله يوفقك يا عبد الله، الله يوفقك، ييسر امرك ان شاء الله، التوفيق ان شاء الله. عبد الله القرني، شكرا يا انفان، اتمنى لك التوفيق، الله يحفظك. نوال، thank you very much, I hope you enjoy it, thank you very much. ريوف، يوسف, thank you very much. Yes عبد العزيز, you can leave, تقدر تغادر. اللي بيمشي يمشي يا اخوان. We are done. Karen, no issues, no problem, don't worry. شكرا يا نوال, اتمنى لكم التوفيق. مريم، عبد الله، سيد. سنة تكلمي مع الادمن، مع الاداره، ما اعرف والله يعني كيف النظام، ما اعرف. اراكم على خير يا انفال، ثانك يو. طيف، سماح، عمر، وريف، سنجي، رفيف، طارق، عابر، سيد، عبد الله، تركي، نوال، ثانك يو فيري ماتش. شهد، كارن، you are welcome. محمد, thank you very much. استودعكم الله في امان الله يا اخوان, ونتمنى لكم التوفيق جميعا. اللي بيمشي يمشي يا اخوان, you can leave. ضحى, thank you very much. زيد, thank you. نورة, يا ليت نورة المزمومي, يا ليت تسألي الأدمن الحاجات التحضير والأسماء هذه ما هي عندي صراحة, فأسألي الأدمن على الموضوع هذا عشان تحل الموضوع معه. اللي سجلتوا معاهم يا إخوان, اللي سجلتوا معاهم الكورس هم الأدمن, يوجهونكم يعني. الساعات متى تنزل نفس الشيء مع الأدمن يا إخوان, مع الإدارة اللي سجلتوا معاهم هم يقولون لكم متى تنزل الساعات, بس هي خلال الأيام القادمة يعني إن شاء الله. شكرا يا أحمد. هاشم, عبد الله, ثانك يو. إيه تقدر تطلع يا سارة, تقدر تطلع, يس يو كان ليف. شكرا يا نورة, شكرا. عمر, اللي سجلت معاهم يا أخي, الواتساب اللي سجلت معاهم في الدورة نفس الرقم يعني. علي الشهري you are welcome. محمد علي thank you. محمد فالح والله يا اخي الايام القادمه يعني تتواصلوا مع الادمن بس خلال كم يوم ان شاء الله يعني. سميحه تواصلي مع الادمن اتوقع ان شاء الله ما في مشكله بس تواصلي مع الادمن لانه اسمك واضح في الزوم. شكرا يا محمد لك التوفيق. والله مو معي يا عبد الله القرني رقم الادمن مو معي. مو معي والله. هذا رقم الادمن ما اعرفه. طيب اذا هذا رقم الادمن يمكن عشان الاخوان يسالوا عليه. اي تقدر تطلع ينوف يس يو كان ليف. والله يا محمد ما اعرف يعني هذه يسال الادمن لانه عندهم الزوم وعندهم التحضير وعندهم كل شيء عندهم. انا والله ما اعرف يعني ما عندي شيء يعني. هذا رقم الادمن مع عبد الله يا اخوان انا ما اعرف والله. بس اتوقع عبد الله القرني انزله لكم على الشات بوكس. شكرا يا وائل نتمنى لك التوفيق عبد الله ثانك يو فيري ماتش. نوال ما اعرف والله اسالوا الادمن يا اخوان بالله متى تنضاف الساعات ما اعرف بس هي خلال اليومين القادمه يعني ما تتاخر. نراكم على خير يا وائل ان شاء الله. ايوه يا فارس تقدر تطلع نعم. ريان الله يوفقك نتمنى لك التوفيق. نوال شكرا جزيلا. اروى ثانك يو فيري ماتش. العنود ثانك يو. منيره ثانك يو. ريان نراكم على خير ان شاء الله. في امان الله يا اماني. نعيمه ثانك يو فيري ماتش. نوال. طيب نستودعكم الله يا اخوان ونراكم ثانك يو مستر احمد. نستودعكم الله يا اخوان ونراكم على خير في دورات اخرى ونتمنى لكم التوفيق جميعا.